Hello.
Start, Manpada. So you can start.
So, sir, we are starting. Anirban, sir, with your permission, shall we start?
Yeah, please, Biju, please.
So, good morning to all of you. I'm Dr. Biju Thomas, the coordinator of this Indian Society of Periodontology Professional Enrichment Program. And it's my pleasure to welcome all the delegates who have logged in today for this program. Now, regarding this program, just a few words about the program. After the new AAP-EFP classification came out in 2017, we have had several workshops and webinars, both at the national and international level, where the new classification has been analyzed and discussed threadbare. In fact, we ourselves had hosted a webinar in 2020 on 6 simple steps for the diagnosis of periodontitis based on the new classification with Dr. Baiju as the speaker. But the fact is that there is more to understand with respect to the new classification, especially how to formulate appropriate treatment guidelines based on the staging and grading of periodontitis. In this context, the S3 level clinical practice guidelines suggested by the European Federation of Periodontology is a practical approach in the step-by-step management of the stage and grading of the patients. Today, our first speaker, Dr. Baiju, will be talking on the treatment approaches based on the S3 level guidelines from an Indian perspective, following which Dr. Ashish Kumar will be talking on the merits and demerits of the new classification, that is a critical analysis of the new classification. Now, as we formally start this webinar, may I invite Professor Dr. Amita Ramesh, Professor and Head, Department of Periodontics, the A.B. Shetty Memorial Institute of Dental Sciences, to formally welcome the gathering.
Thank you, Dr. Biju. Respected dignitaries, Dr. U.S. Krishnaik, Dean and Principal ABSM IDS, President ISP Dr. Anirban Chatterjee, Secretary ISP H.S. Grover, Scientific Convener Dr. Shipra Gupta, PEP Coordinator Dr. Rameshwari Singhal, Vice Principal Dr. Mitra and Hegde, speakers for today's program Dr. Baiju and Dr. Ashish, Dean and HODs, faculties of various institutions who have logged in, HODs and faculties of ABSM IDS, postgraduates of various institutions and our institution. A very good morning to one and all. Today's topic, International Perspective of Guidelines of Periodontal Therapy as per the new classification. The current international guidelines for periodontal therapy aims to support improvements in patient care by bringing together in a structured manner the best available information that can be interpreted easily and implemented in day-to-day clinical practice. Makes use of the best current research evidence, taking into account the clinical expertise and preferences of the patient to make informed decisions in the patient care. So today, we are waiting for this program quite some time. Today, we have with us eminent speakers with extensive knowledge delivering this lecture today. First of all, I would like to welcome our Dean and Principal, Dr. U.S. Krishnaik, who has always been a support in all our endeavors. I welcome you, sir. I also welcome our President ISP, Dr. Anirban Chatterjee, who has taken his time out of his busy schedule and logged in for this program today. I welcome you, sir.
Thank you.
I also welcome our Secretary ISP, H.S. Grover, for gracing this occasion and sanctioning this program. I welcome you.
Thank you, ma'am.
I welcome Dr. Mitra and Hegde, our Vice Principal. I welcome you, ma'am. I also welcome our speakers for today's program, Dr. Baiju and Dr. Ashish. Dr. Baiju will be talking on international perspectives of guidelines of periodontal therapy, and Dr. Ashish will be talking on merits and demerits of the new classification. I'm sure it is going to be a very fruitful lecture. We're all eagerly waiting to listen from our renowned speakers. I also welcome our scientific convener, Dr. Shipra Gupta, and also our PEP coordinator, Dr. Rameshwari Singhal, for this program. I welcome all the HODs, faculty of the neighboring institutions and also our institutions. And I also welcome the postgraduates all over India. I see there are more than 1,000 participants for today's program. I welcome all of you all wholeheartedly. I kindly request all of you all to participate and interact in this program. I'm sure it's going to be a very beneficial one. I welcome you all once again. Thank you.
Thank you, Professor Dr. Amita, for those encouraging words. Now, this being a program under the Indian Society of Periodontology, and as all of you know, after the new team of office bearers led by Dr. Anirban has taken over, this is the first program. And it is, as one of the office bearers of the ISP, it is my duty to acknowledge all the other office bearers of the ISP also who have logged in today. Other than our president and secretary, we have President-elect Dr. Abhay Kolte, the immediate past President Dr. Nimfia Pandit, the Vice Presidents Dr. Manish Khatri and Dr. Baljit Singh, the Joint Secretary Dr. Vishaka Grover, Treasurer Dr. Neeraj Deshpande, Editor of course Dr. Ashish Kumar, the Scientific Program Convener Dr. Shipra Gupta, the Periodontal Healthcare Convener Dr. Sanjeev Salaria, and the Coordinator of the ISP PEP Dr. Rameshwari Singhal, the past Presidents Dr. Ashish Jain, Dr. Anil, Dr. Praveen Kudva. I welcome all of you for this program. Now, Professor Dr. U.S. Krishnan Nayak, the Principal and Dean of the A.B. Shetty Memorial Institute of Dental Sciences, the driving force behind all our programs and who has been a source of great support and encouragement for us to organize this program. Sir, may I welcome you to deliver the inaugural address and formally inaugurate the program.
A very good morning to all of you who have logged in for this professional enrichment program being conducted by the Indian Society of Periodontology. My very dear friend, the President of ISP, Professor Dr. Anirban Chatterjee, the Secretary of the ISP, Harpreet Singh Grover, the guest speakers of today's program, Dr. Baiju Madhavan and Dr. Ashish Kumar, the Professor Dr. Biju, one of the members of the Executive Committee of the ISP, Professor Dr. Amita, the charming Head of Department of Periodontics at our institution, past presidents of Indian Society of Periodontology, the newly taken over team of the Executive Committee include the names were just read out by Biju. I think Abhay Kolte is very familiar to me, but I couldn't recollect all the names, but there were quite at least a few names which are very familiar. And I'm really impressed when Amita told me that close to 1,000 people have registered for this program online, including postgraduate students, staff members from across the country. I really deem it a pleasure and privilege to be participating or to be part of this professional enrichment program being conducted by the Indian Society of Periodontology in association with the Department of Periodontics and the Dental Education Unit of our institution. I should first of all congratulate Professor Dr. Amita and Professor Dr. Biju for bringing this program or hosting this program at our institution. And of course, this wouldn't have been possible without the office bearers of the ISP, Professor Anirban, Professor Grover, and each one of you who for allotting this program to our institution. Over the years, even when Dr. Biju was the head of department, I used to see at least 1 or 2 programs in a year of ISP being conducted at our institution of various kinds. So a program of ISP being held at our institution is nothing new. But what is new is the team of office bearers led by Anirban. I understand this is the first program. It is under their stewardship. I congratulate them and I wish them all the very best for their future endeavors in their term. I'm sure well begun is half done, they say. And the program, well, it may sound like blowing our own trumpet. The program starting at AB Shetty, I'm sure things over the year will go on very smoothly and successfully. I wish the new team all the very best, and I'm sure each one of the programs is going to be a super duper success. I will be failing in my duty if I do not welcome the guest speakers, Professor Dr. Baiju and Professor Dr. Ashish, for taking the time out and participating in this webinar. I'm sure all the participants are going to go richer in knowledge at the end of this webinar. And once again, congratulations, Dr. Biju, Dr. Amita, and all the other staff of the college, especially Department of Periodontics. And I would like to specially mention the name of Dr. Rahul Bhandari, Professor Dr. Rahul Bhandari, who incidentally is also a periodontist, is also the chairman of the dental education unit of our institution. He has been instrumentally not just organizing this program, but various other programs of all the departments. They come under the dental education unit, which we have launched about a year back. Since then, it has been firing on all cylinders, and the very enthusiastic Dr. Rahul Bhandari has been conducting programs after programs, even in this trying times. You know what I'm talking about with this COVID, etc. But we did go physical in between when things were slightly better. Again, with a spurt of cases, we are forced to have this program, the various programs online. Anyway, I'm sure people, there are always pluses in any situation. Now, today, about 1,000 people across the country can log in and listen to our speakers. If it was physical, probably that many couldn't have come. So let's look at the positive in every aspect. Let's not pick up on, what is lost. So the positive is that, and the many more positives. And thank you very much, Anirban and Dr. Harpreet.
Thank you, sir.
For adopting this program to our institution. I'm very grateful to you, and I wish the program all success. Thank you very much, and have a great day ahead.
Thank you so much, sir.
Thank you. Thank you.
Thank you, Krishna Naik, sir, for inaugurating that program and your warm words of encouragement for all of us to conduct more programs in the future. Now, the president of the Indian Society of Periodontology is the first citizen of the society. The post carries respect, and all over the last 2-3 decades as office bearers of ISP, we have always learned to respect and honor the president. This year, we have a president who needs no introduction to anybody. He is very popular all over the country. And Grover sir will also agree with me that Anirban need not be formally introduced here because he is very well known.
Absolutely.
Anirban, protocol demands I should address you as Honorable President, but our rapport of the last 25 years, I take the liberty to address you by your first name. I hope you don't take personal umbrage to it. Now, may I formally invite you to deliver the presidential address.
Thank you, Dr. Biju. It is a pleasure to be inaugurating the first program of our ISP for this year 21-22. Actually, we had other programs of colloquium series, as you all know, which was postponed for a later date due to this COVID. But as it is really overwhelming for me and proud moment that we are starting the program with PEP from Mangalore. Very close to my heart because as I was talking, immediately after my post-graduation 96, 97, there was a ISP program and attended, and it was a pleasure to be there as a staff. And my relationship with our principal, sir, Dr. Krishna Naik, goes way beyond almost more than 20-21 years. Since I was in ISP, even Dr. Grover is there. He has been in ISP in various posts. I was there with him for a pretty long time. So it is under the leadership of such a person, Dr. Krishna Naik, I would like to call him as the cementum of AB Shetty. Cementum with his a dynamic man, always having a So it's Dr. Krishnayak, Cementum Krishnayak, sir. So it is a pleasure, sir, to be under your guidance, Dr. Biju, Dr. Amita, Dr. Rahul, and all of them are there. This program is being conducted. And it was really something good that we have among us a person whom I know from last 25 years, a very polished, refined man of word, and I would tell a gentleman, Dr. Biju Thomas, who has been always in the forefront of our ISP. I would tell he is one of the dawn of ISP, who has been leading from the front. Biju Thomas leading from the front and always been supportive. I'm so thankful that I have no words to tell about him. It's not about praising him or patting my own self to tell. It was such a relationship, such an honorable gentleman. An honor to be with his guidance. I have also come across as a president, and there is time when I have taken his guidance also for various factors, various reasons, and I have my secretary to vouch for it. And I have always taken also a guidance from our Honorable Secretary, Dr. H.S. Grover. And it's a pleasure to tell you that there has been a lot of debate about this topic of classification. And we have a person among us, Baiju, who has worked a lot on a classification. More than that,
yes, sir.
More than that, I have Dr. Ashish Kumar, our editor.
Sure.
Editor who has been, classification is in his blood now. Dr. Ashish Kumar's, it has been there. Classification of new. I wanted to have a classification of periodontitis, what is there from 2017 onwards, on an Indian perspective. I was discussing, I don't know, during my tenure, whether we can discuss and whether we can have take some our periodontists into being and then make an Indian perspective of a classification, which needs to be gone on, because there are classifications which has been prospected from the UK, other countries, but we never had an Indian perspective, how we came out with the diabetics on a guidelines for diabetes. So likewise, I would wanted to have that as present. So I think it is a wonderful start for our session or season, and might be it will take us forward towards developing some new system, new classification with the help of Ashish, Baiju, Biju, and other stalwarts of our Indian Society of Periodontology. Plus, it is very heartening to hear that more than 1,000 people have registered. Actually, I'm getting a lot of WhatsApp that we are not able to log in. I told them to see into the spam. We have registered. We lot almost HODs of different various colleges are wants to log in. I don't know if Rahul can help them out with this. So with this word, as you know, Perio has been always in the forefront and has been a leader in various doing various programs. Let it be a initial teachers training program, PPs. Let it be a oral hygiene day. Let it be something giving awards to students. This year we have come with flurry of programs also added to what we were doing, like something like we have thought of going for teachers award and all those things. Hopefully we will be coming out with other different programs also. So with this, I would like to thank Principal Dr. Krishnayak sir, Dr. Biju Thomas, who had been kind enough to call me for this inaugural to be a chief guest, Dr. Amita Ramesh, HOD, Dr. Rahul Bhandari, and all the HODs of Mangalore colleges, as well as all various HODs and the staff who have registered and who are there in the program. plus the students, PG students, who are definitely going to benefit. Only question what I would ask the PG students to actively participate, just not log in and just do their other work and then come in the end of the program to get a certificate, virtual certificate or whatever. It doesn't serve the purpose. We are here to share knowledge, and we have two of the best of them who will be sharing knowledge with you. Kindly put on questions across in the chat box so that it can be discussed at length. Time is not the factor. I think Baiju and Ashish both would be very happy enough to answer all the queries. So it is my personal request to all the postgraduates, even the staff, even the HODs, even there is nothing wrong. You will get more knowledge as you have interaction with it. With this, thank you very much, everyone, for your kind and patient hearing. Thank you. Thank you.
Thank you.
Thank you, Dr. Anirban, for your presidential address. It was really a pleasure to listen to all of you, and you have conveyed the right message to all the fellow ISPNs who have logged in. Just an announcement, I heard you telling about the difficulty of logging in. When all of you who registered would have immediately got a mail from the Staff Development Center, the SDC mail. But what has happened is, for many of you, the mail has gone to your spam accounts. That is a problem. So those who are didn't get the mail, kindly check your spam accounts. Definitely that mail will be there in your spam account. So those of you are already listening, and some of your friends who may not have been able to log in because of this problem, kindly inform them just to check the spam account, because everybody has promptly got a mail from our University Staff Development Center. And again, Anirban has told about the chat box. We are monitoring the chat box. Postgraduates and faculty, please feel free to put your questions in the chat box. It will be taken up after both the lectures are over. Now, the secretary of the Indian Society of Periodontology is the backbone of the society. A man who handles thousands and thousands of periodontists and budding periodontists, patiently listening to their queries, replying to them, and taking the society forward. I would like to say today we are lucky and fortunate that we have a person like Dr. H.S. Grover, very mature, seasoned periodontist, who really is taking our society forward. And in spite of his hectic schedule, he agreed to spare time to be here with us today morning. Sir, may I invite you to address the gathering?
Thank you, Dr. Biju. Honorable President of ISP, Dr. Anirban Chatterjee, Honorable Dean, Professor Krishna Nayak sir, Amita ma'am, our very own Dr. Biju, Dr. Bhandari, opening batsmen for ISP session this year, both Dr. Baiju and Dr. Ashish Kumar, who are speakers also. First of all, I would like to thank you all for organizing such a wonderful, virtual program. And as Dean sir rightly said, well begun is half done, and starting from college, which has a great heritage, A.B. Shetty, ISP is really very happy to have started this partnership for this year with A.B. Shetty. Now, coming to today's topic, we all know that classification is a big mystery to all of us, our undergraduates, postgraduates, and even to the teachers. So decoding or demystifying the classification has remained the need of the hour for our student community for a long, long time. And as we understand, today we have one of the best exponents on the said topic who will definitely, unravel the mysteries associated with this topic. I also thank my colleagues in the ISP office bearers and EC members who have today logged in to make this program what it is going to be. And once again, my best wishes and greetings from New Delhi to all of you who are associated with today's program. Happy learning to all of you. Thank you so very much. Good morning once again.
Thank you, sir, for the Secretary's message to all the ISPNs who are attending this program. Now, this being an online program, we'll just finish the vote of thanks before going on to the speakers. Now, may I invite Dr. Mamta Shetty from the Department of Periodontics to deliver the vote of thanks. Just a second, she's coming online. Dr. Mamta?
I think she's just connecting. She's just some problem with the connection. She's coming in.
Shall we take up the vote of thanks later then?
Coming, I think.
Coming.
Respected dignitaries, faculty members, and postgraduate students, good morning to all. I deem it my pleasure to propose this hearty vote of thanks on this professional enrichment program organized by Indian Society of Periodontology. First and foremost, we would like to thank our dynamic dean, Professor Dr. U.S. Krishna Nayak, for his constant support, presence, and valuable words. Thank you, sir. We would like to thank our Vice Dean, Professor Dr. Mitra N. Hegde, for her gracious presence and constant support. Thank you, ma'am. We would like to thank President of Indian Society of Periodontology, Professor Dr. Anirban Chatterjee, for taking his time from his busy schedule and gracing today's occasion as a chief guest. Thank you, sir. We would like to thank the resource person of today's program, Professor Dr. Baiju and Professor Dr. Ashish Kumar, who will be sharing their valuable knowledge on current international guidelines for periodontal therapy and merits and demerits on new classification with all the participants in a short while. We are also thankful to our Secretary of Indian Society of Periodontology, Dr. H.S. Grover, for his support and guidance in conducting today's professional enrichment program. We extend our heartfelt gratitude to Dr. Shipra, ISP Scientific Program Convener, and Dr. Rameshwari Singhal, ISP Coordinator for Professional Enrichment Program, for their continuous support in organizing and conducting such programs. We are also thankful to Head of the Department Periodontics, Professor Dr. Amita Ramesh, and Program Coordinator, Professor Dr. Biju Thomas, and Professor Dr. Rahul Bandari, for being instrumental in organizing today's program. We are thankful to all the office bearers, EC members, life members of Indian Society of Periodontology for their active participation and support in organizing the professional enrichment program. Lastly, we are thankful to all the postgraduate students who are backbone of our specialty, and also all the participants for taking keen interest and enrolling in today's program. Thank one and all the participants. Wish you all a great day and a happy learning. Thank you once again.
Thank you, Dr. Mamta, for those vote of thanks. Now, as we formally get on with the program, it's my pleasure to invite Professor Dr. Rahul Bandari, Professor, Department of Periodontics and the convener of the Dental Education Unit of our institution, to introduce the first speaker of the day, Professor Dr. Baiju Madhavan, Professor from Government Dental College, Kotte. Over to you, Dr. Rahul.
A very good morning, dear dignitaries. It's my pleasure to introduce Dr. Baiju RM, who will be speaking on the topic Current International Guidelines for Periodontal Therapy, the Indian Perspective. Dr. Baiju is currently the Professor of Periodontology, Government Dental College, Kottayam, Kerala. He did his BDS in the year 1994 at Ragas Dental College and passed with the first rank. He completed his MDS in Government Dental College, Trivandrum, and did his postgraduate in clinical research in 2011 in Annamalai University. He is also a PhD awardee from the University of Kerala. He did his FDS RCS from the Royal College of Physicians and Surgeons, and also has done his PGD MLE from the National Law School, Bangalore. He has a wide teaching experience of over 22 years after MDS. He is a PG guide since 2011. He's also a PhD guide at the Kerala University of Health Sciences. He's a widely invited key speaker and a resource person at various forums. His areas of interest include periodontal regeneration, implantology, medical law, and ethics. He has a wide number of publications on over 50 PubMed and Medline Index journals. He has more than 250 citations in PubMed, and he's also edited a textbook for Springer, which will be published very soon. I heard that he recently, a prestigious publishing house has released his Malayalam short stories for one to his credit. And he's also a member of Board of Studies of Kerala University. We formally welcome you, sir, and invite you to go ahead with your presentation. Thank you.
Thank you, Dr. Rahul, for the introduction of Dr. Baiju. Baiju, the floor is yours now. You can go ahead with the program.
Sir, am I audible, sir?
Yes, you are audible, Baiju. It's very clear also. You can share the screen.
I've already shared the screen. Is it visible? Can you see the screen now?
Not as yet, sir. Not as yet.
Yes, Baiju. It's visible.
Thank you, Dr. Rahul. Thank you, Dr. Rahul, for the kind words. Honorable President, Dr. Anirban, Secretary of ISP, Grover, sir, respected Principal of AB Shetty, Krishna Nayak, sir, Dr. Biju Thomas, as Dr. Anirban mentioned, the one of the dons of ISP, most respected Head of the Department, Dr. Amita, Dr. Rahul, Dr. Shipra, Dr. Rameshwari, and all the delegates who joined for this program. A warm welcome to you all. Today, we shall discuss about the current international guidelines for periodontal therapy from an Indian perspective. Now, periodontitis, we all know, is a highly prevalent condition affecting more than 50% of the population. In spite of being, it has a very highly prevalent condition, in spite of being linked to as a risk factor for major systemic life-threatening conditions like diabetes, cardiovascular disease, stroke, etc. In spite of being one of the difficult conditions to treat, we still don't have any practice guidelines, any standardized protocol for managing periodontitis, at least in India. On this premise, we are discussing this paper. This is an enormous document that is published by the European Federation of Periodontology, known as the S3 level guidelines. So we are trying to look at these guidelines when none such protocols exist in India. So if you look at if you scroll internet, if you Google it as clinical guidelines available in India, you'll get a lot of guidelines for managing systemic diseases. You have guidelines for managing coronary artery disease. You have guidelines for managing valvular diseases. You have guidelines for managing
stroke victims, so on and so forth. Almost all the specialties have their own guidelines for their individual clinical conditions. But in spite of being such a wide prevalent condition, we still lack guidelines. So what we are trying to see in this is the only guideline that is available for us now. And this is a very high quality guideline because it has been based on current systematic reviews. So this presentation, what I'm trying to see is I'm trying to look at this guidelines from an Indian perspective so that what is its significance for an Indian periodontist. So what is in it that is applicable or that is interesting to a postgraduate student in India? So what is it that can change the way we practice? I can assure you that these guidelines will definitely influence the way we practice periodontics. There is no doubt about it. It is really going to streamline, it is really going to reconfirm certain decisions that we are already making. It is going to change certain decisions that we've been making, and it's definitely going to throw some light on the way how this has to be managed. The disease has to be managed for successful outcomes. So with this brief introduction, let me begin the presentation as such. As you all know, the premise or the background for the guidelines is the 2017 classification, which will be discussed in threadbare by Dr. Ashish Kumar. He's, as Dr. Anirban mentioned, is the classification man for us. But a few words regarding the classification. You all know it has revolutionized the way we diagnose periodontitis. It has brought in a lot of objectivity in the diagnosis. It not only describes the disease in its severity and extent, it also considers the patient's individual risk for developing the disease. It also considers the degree of complexity in managing the disease. But this classification has paved a way for a need for an evidence-based guideline. Now, the European Federation of Periodontology, in their Perio workshop in 2019, they have discussed this. They have commissioned 15 systematic reviews just for this, for the development of this guideline. So they have taken or they have considered all the interventions that are now available for managing periodontitis, right from our scaling, oral hygiene instructions to the latest available intervention that is there that we are practicing throughout the world. They have considered all the interventions and they have formulated PCOS questions or focus question based on a PCOS format. And they have commissioned 15 groups for review to appraise the evidence. And they have come out with some 60 clinical recommendations. All this, the beauty of these recommendations is that they are internationally adaptable. And as we go further in the presentation, you will know that it's very easy for us Indians also to follow these guidelines and to adapt it and apply it to our patients. And as it is mentioned in the guidelines itself, it is a supranational guidelines. Already many countries have started incorporating these guidelines into their health system. And according to the EFP, these guidelines will get revised every 5 years because as new evidence comes in, as new knowledge is appraised, new knowledge is acknowledged, which will definitely change our practice. They will definitely going to revise these guidelines in 2025. Now, there are these two publications, one by the original publication written by Mariano Sanz and colleagues, published in the Journal of Clinical Periodontology in July 2020, is the first paper that is the basis for the presentation. And also there is another related paper which came in Journal of Dentistry in 2021, published by the British Implementation Group. The British have tried to adopt and try to modify these guidelines into their health system. So they have made some little modifications according to their health system. And today, what I'm trying to see is from an Indian point of view, we're trying to see what guidelines are what are the ways by which we can use these guidelines to our practice. Now, we all know that this is the stepping stone. This is a foundation for our clinical decision making. Nowadays, it is mandatory to make all our clinical decision based on the available evidence. You know, this is the evidence pyramid. And it's also important from a medical and legal point of view. Because if you're not making your clinical decisions, you're not providing treatment, not based on the available quality of evidence, then you will not be doing the right practice. And also we have this appraisal, or we have this hierarchy of the quality of evidence. We know the randomized controlled trials are the standard for any quality evidence, and systematic reviews of these randomized controls are higher than these randomized controlled trials in terms of the quality of evidence. And at the top of the pyramid, as you can see, the top of the pyramid, you have this the evidence-based guidelines, or these guidelines that we are going to discuss today are at the pinnacle of the pyramid. So it is a highly appraised evidence, and it is also evidence-based. Now, what is this S3 level guidelines? So this is the categorization of the guidelines. The guidelines development group have categorized into various levels. The basic is the S1 recommendation, where you have an informal process of formulating guidelines. A few experts will come together on behalf of a society and will form a guideline. And S2C is a little more higher level, where you have this consensus-based guideline. There is a representative group, members from various stakeholders, including other specialties, also come together, and then they also give their inputs in formulating the treatment guidelines. And S2E is a little more higher, where you have this evidence-based guidelines, where the systematic reviews are also taken into consideration. They are also considering evidence, not expertise. They're also considering evidence. Now, S3 is the highest level, where we have the combination of evidence and the consensus. So they are not only considering the available evidence, but also they are also deliberating this evidence among the experts, and based on a consensus, they come out with the individual recommendations. Now, since the advent of the new classification, the diagnosis of periodontal disease has become very easy. It is not at all hereafter. It is no longer a clinical thing. It's no longer an academic thing. A diagnosis of periodontitis can be done not only in the periodontal PG clinics, it can be done in any clinic, in any setting, in any dental, in any normal dental clinic. Any dentist can make the diagnosis in a span of less than a minute, if you have the radiographs. So the diagnosis for periodontal disease has shifted from detailed periodontal charts to radiographs. If you have radiographs, you can make a diagnosis. And if you have additional features like risk factors and charts, you can actually formulate the treatment. So for formulating the treatment, you need the charts. For diagnosing the periodontitis, if you have a good quality radiograph, that is sufficient. So today, the guidelines we are trying to discuss are for stage 1 to 3 periodontitis. Stage 1 means it's a mild periodontitis. Stage 2 is the moderate periodontitis, where the bone loss has reached up to the coronal third. And stage 3 is where there is 50% bone loss, and we call it as severe periodontitis. So the guidelines that we are going to discuss today includes the management of mild, moderate, and severe periodontitis, but it does not include the management of stage 4 periodontitis or advanced periodontitis, or very severe periodontitis, where the bone loss has reached up to the apex of the root. So once the bone loss has reached up to the apex of the root, the prognosis of the tooth becomes very poor. Many times the tooth will go for extraction, and the management is totally a different, we have to discuss it in a different setting. So these guidelines will not cover stage 4 periodontitis. These guidelines will not cover necrotizing diseases. Also, the mucogingival conditions are also not taken into consideration. These are the 15 systematic reviews that form the basis for development of the guidelines. And they have graded these individual recommendations. So these initial slides, I'm trying to explain the language of the guidelines so that it becomes easy for you to understand when I go deeper into the individual stepwise treatment approaches. So this is how they have graded the recommendation. Suppose they have given grade A, that means it is a strong recommendation. And a strong recommendation can be a strong positive recommendation where there are 2 upward arrows. So these 2 upward arrows denote that what the recommendation that they are giving is a very strong recommendation, and that is very good evidence based to it. And also they can give a recommendation, very strong recommendation in a negative connotation. That means we recommend not to use. Certain situations, they'll recommend certain things not to be done. If that recommendation is very strong, again, there will be 2 arrows pointing towards the downward direction. The grade B recommendation is a recommendation in which they have mentioned it as we suggest to. It also can be a positive or a negative recommendation. And when you have an O or an open recommendation, that means the evidence is not that strong for that recommendation, so that they cannot give any strong recommendation either in favor or against. So that is the individual clinician can maybe consider to apply this recommendation or not based on their expertise and the given clinical case. Similarly, there is also, apart from the grading, there are also consensus. The members of the group, they will come to an agreement based on how many of them are actually in favor of it. If all of them agree, it's a unanimous consensus. If less than 50% is not agreeing, then there is no consensus. Now, the British Society of Periodontology has given the stepwise approach or the management of periodontitis into various steps. First thing is a step 0. Step 0 is at the level of diagnosis, where you're diagnosing the condition. At the time of diagnosis, you will appraise the patient's oral hygiene practices, the risk factors. You will educate the patient regarding their oral hygiene practices. You will motivate the patient. That is step 0. Once the diagnosis is made, first step is the supragingival scaling and oral hygiene instructions, or in fact, it is known as the risk factor control. You're trying to appraise all the risk factors and you're trying to control the risk factors. Without risk factor control, you cannot guarantee successful periodontal therapy. And step 2 is a real intervention where you do the subgingival instrumentation. In step 1, only supragingival instrumentation is done. Step 2 considers the subgingival instrumentation. And next step is the re-evaluation or rechecking. You're trying to see whether the endpoints of therapy have been reached, because the first 2 steps is the non-surgical therapy. What is the result of non-surgical therapy? Were you able to achieve the results that is needed for that particular patient during that re-evaluation phase? And if there are still non-responding sites, then you will initiate the surgical therapy. So step 3 is re-evaluation or reassessment followed by surgical therapy. And as we all know, the final thing is the supportive periodontal therapy, because there is no exit plan in perio. Because once a periodontitis patient, as the new classification tells, you are a periodontitis patient for life. So they cannot exit from this treatment plan, but they'll enter into a new phase called the supportive periodontal therapy. This is another way of representing the stepwise pattern. The basis is the diagnosis of the condition based on the new classification. Once the diagnosis is made, definitely they'll go to step 1, step 2, and step 3. And as and when the endpoints are reached, they'll be taken to step 4. This is another way of looking at the various steps. As you can see, stage 1, stage 2, and stage 3 periodontitis. For all these stages, the step 1 is mandatory. Okay, the initial supragingival scaling and the plaque control instructions, they are mandatory for all stages of periodontal therapy. Subgingival instrumentation or step 2 is done only in affected teeth, only in teeth that have deep pockets or more than 4 millimeter. When you do the subgingival instrumentation, you will be doing it under local anesthesia, but only for those teeth that are indicated for subgingival instrumentation. And it is also applicable in all stages of therapy, all stages of the periodontitis. And surgery is not applicable for mild to moderate periodontitis. So this is a thing that we should be actually looking at. Because if you have diagnosed this patient as mild periodontitis or moderate periodontitis, and you are writing in the treatment plan periodontal surgery, then you'll be in trouble, because you are not going according to the guidelines. So no surgery for patients from mild to moderate periodontitis. Surgery is only indicated in affected teeth for severe periodontitis, where there is 50% bone loss or more than 6 millimeter pockets. And that too is decided after the step 1 and step 2 therapy, the time of re-evaluation. And SPT or step 4 is mandatory for irrespective of the stage of the disease. Now we are going into the individual clinical recommendations from an Indian point of view. So now coming to step 0. Step 0, as I mentioned, is the diagnosis and patient counseling. There are certain essential prerequisites for beginning therapy. First, you have to inform the patient about the diagnosis. What is their condition? What is the stage of their disease? What is their grade of their disease? You have to mention that, because they also should know what is the status of their periodontium. Then once you make the diagnosis, you have to look for the causes and the risk factors. What are the risk factors that are particular for your particular patient? What are the specific risk factors in that patient? Then you have to discuss about all the treatment options including the option of not treatment. Because some patients in India, we all know that periodontitis is a silent disease. So it may not be many symptoms for periodontitis. And many a times, mild to moderate periodontitis are diagnosed in a dental clinic when the patient comes for some other purpose. And the patient may not be coming for treatment if they are suffering from mild to moderate periodontitis. But very severe periodontitis or very severe periodontitis, there will be symptoms and they'll come for treatment. So if you're diagnosing a mild periodontitis or a moderate periodontitis and the patients are having no symptoms, they'll be reluctant to undergo treatment. So you have to explain them what will happen if you're not undergoing treatment. What are the outcomes that can happen if periodontal treatment is not undertaken? You can explain about the systemic risk. You can explain about the connection between periodontology and the cardiac outcomes, the atherosclerotic cardiovascular disease. You can also discuss about the adverse pregnancy outcomes if the patient is a pregnant patient or an expecting mother. You can also discuss about the other the influence of periodontitis on diabetes. So all these things should be discussed at step 0, and you have to formulate a personalized care plan. Personal care plan is very important because each plan is different for each individual. And once the patient is agreeing upon your plan, you have to obtain a signed informed consent. Now, this is a significance of individually tailored approach because patient categories, they are diverse. They have diverse immunological responses. They have diverse risk factors. They have diverse behavioral aspects. They have diverse capabilities in plaque control. And also they have diverse attitudes towards periodontal treatment. So a standardized approach may not work for all of them. It may be effective only to 20% of your population. So there are other categories of patients who require specific treatment plans. So we have to formulate an individually tailored treatment approach for our patient. Now moving on to step 1. This is the first step of therapy. It actually it discusses 3 things. One is the biofilm control. This is the most important thing in step 1. You're trying to control the biofilm, the most important risk factor, that is the dental biofilm. The dental biofilm control is done by the patient. Instructions and motivations are your efforts to reinforce or to make sure that the patient is practicing good oral hygiene. And if you put 20% efforts to maintain oral hygiene, the patient should put 80%. That means the success is guaranteed only if the patient is willing to contribute, willing to put his efforts in maintaining the oral hygiene. So that has to be informed with him. And then comes your role, that is the biofilm control by the professional. They have introduced a new term for that, that is supragingival professional mechanical plaque removal. This is a new term for biofilm control by the professional. Here, the biofilm control, we are limiting only at the level of the supragingival level. And also, we have to take into consideration the risk factors, and you have to address that. Now, there is strong recommendation for patient self-care. There is no doubt about it. Nobody will doubt that the patient's role in oral hygiene importance is very, very important. Nobody will have a second opinion on that. And there is a supporting literature for this. Slots systematic review that gives an A-grade recommendation, 2 upward arrows, that it is a strong recommendation for the patient to practice his oral hygiene. Then comes the professional's role, the supragingival dental biofilm control by the professional. That also has a very strong recommendation with the 2 arrows. But if you employ supragingival plaque control, especially in patients with more severe disease, you may think that what is the role in doing supragingival plaque control alone? But supragingival plaque control, once you do, that will decrease the need for subgingival treatment in some patients. And also there is a beneficial change in the subgingival microbiota that comes. So that is also important. Now coming to the risk factor control in periodontal therapy. We know there are 2 recognized risk factors, that is diabetes and smoking. The new classification considers smoking as those who are non-smokers or smokers who smoke less than 10 cigarettes and smokers who smoke more than 10 cigarettes. So that is one of the specialty of the new classification. It is giving some objective parameters, bringing some objective parameters to each and everything. So smoking, suppose your patient is a smoker, the first thing to do is you should motivate him to quit smoking. If not, if he is not willing to quit smoking, at least you should ask him to bring down the number of cigarettes that he takes to less than 10. And similarly, if a patient is diabetic, ideal thing is normoglycemic, but if he is diabetic, you have to check the HbA1c level. And 7 is the threshold. The target should be 7. You should be trying to reach 7 in order to get positive outcomes of periodontal therapy. So only if it is 7, it is well controlled. Above 7, it is poor controlled. So as part of the step 0 or step 1, you send for a HbA1c evaluation for your patients, assess the HbA1c level, and try to bring it down to below 7%. So there is again a very strong recommendation according to the systematic review by Ramsier in 2020 regarding the risk factors. Risk factor control is absolutely essential for the success of periodontal therapy. There are other risk factors that are being discussed. You will find in journals that weight reduction or physical activity or healthy diet influence periodontal disease, obesity. You will find all those things in journals. But right now, there is no strong evidence base to state that all these things are important, even though those things will definitely improve their general health. But these two things are very important. Now, this is a summary chart published by British Society of Periodontology. They have replaced the old terms like scaling and polishing and prophylaxis with a new term that is supragingival plaque control, supragingival PMPR or professional mechanical plaque removal. In India, we still use this word oral prophylaxis. At least in Kerala, I know many centers, many dentists, many specialists, and many periodontics departments still use the word oral prophylaxis. And oral prophylaxis is a generic term that is that denotes that you are doing some preventive therapy to a periodontally healthy individual. If you're giving some treatment to a periodontitis patient, you cannot call it as prophylaxis. It has to be a non-surgical periodontal therapy, or if you are doing it in the supragingival level, the new term is supragingival PMPR. Similarly, with subgingival treatment, these are the various terms that we have been using for subgingival instrumentation. You will see scaling of the root of the teeth, subgingival scaling or subgingival debridement, subgingival instrumentation or root surface debridement or root surface instrumentation. All these terms are now replaced with subgingival PMPR or subgingival professional mechanical plaque removal. Now, the new guidelines document is putting an end to the obsolete terms like oral prophylaxis, root planing, and curettage. Root planing, I think for the past 20 years, that root planing term has been found to be not appropriate because the works by Hughes and colleagues right from the mid-1980s, they have shown that the endotoxins will not go very deep into the root surface. It will go only, it is absorbed only to the surface of the root, so that ultrasonic instrumentation or washing of the root surface by means of repeated ultrasonic instrumentation or mild root surface instrumentation by the use of curettes alone is sufficient to remove endotoxin. You don't have to remove considerable amount of cementum or even dentin to achieve successful periodontal outcomes. So root planing is, even though there is no evidence base for the term root planing, our journals still use this term SRP. And curettage, many of our specialists still refer curettage for subgingival instrumentation. And hereafter, since the new guidelines document, curettage is mentioned only as a treatment for draining a periodontal abscess. So no longer these terms we can use because there is no evidence for these terms. Now coming to the step 2. Step 2 is actually the cause-related therapy where we perform the subgingival instrumentation in selected sites. What are the selected sites? Sites that are indicated for subgingival instrumentation are sites with deep pockets more than 4 millimeter. So in such situation, when there is a 4 millimeter pocket that bleeds, you have to instrument there subgingivally. Whenever you do subgingival instrumentation, it has to be done under local anesthesia. And of course, there will be generalized deep pockets. Most of your patients will have pockets in all quadrants and pockets in the range of 6 millimeter or above. In such situations, you can combine the supra and subgingival instrumentation together. There is no point, there is no contraindication to that. So it doesn't mean that you have to practice step 1 alone and step 2 alone. If there is clinical indication that the deep pockets we all know that in deep pockets, if you are doing only supragingival instrumentation, that may lead to abscess, development of periodontal abscess. If the clinician fears that, in such a case, if you are doing only supragingival instrumentation, if it results in development of periodontal abscess, in that situation, you can combine step 1 and step 2 together. And next comes the re-evaluation, which is done after 3 months. You do the re-evaluation after 3 months. Now, in non-surgical therapy, there are these dilemmas that we have in our day-to-day practice. We'll have this doubt: how beneficial is subgingival instrumentation for the treatment of periodontitis? Is there any difference between hand instruments, powered or ultrasonic instruments, or a combination of them in terms of healing outcomes? Also, you'll have this doubt whether how to deliver your subgingival treatment, whether to do a quadrant-wise approach or in multiple visits, whether you're planning to do 1 quadrant scaling on 1 day and recall the patient after 1 week and do the 2nd quadrant, or there is a popular concept called full mouth procedure or full mouth disinfection, which is done within a span of 24 hours. So there is strong recommendation, a grade A recommendation for subgingival instrumentation to be employed to treat periodontitis in order to reduce PPD, gingival inflammation, and number of disease sites. So before jumping into periodontal surgery, you should always utilize this step. Subgingival instrumentation should be done as a mandatory step. The pocket is very deep. The grade of recommendation here is very strong. The next question is there any difference between the outcomes if you employ hand instrumentation, powered or ultrasonic instruments, or a combination of them in terms of healing outcomes? Now, the COVID situation, most of us have resorted back to our hand instrumentation, and many of our students are now phenomenally skilled in hand instrumentation thanks to the COVID pandemic and the lockdown. Fearing an aerosol contamination, many of our students and many of our professionals went back to hand instrumentation. Hand instrumentation are really, really good, but the problem is the issue of over instrumentation. If you over instrument, there is going to be sensitivity, and the patient may have sensitivity after the treatment. Now, this literature by Suvan, the systematic review, which included 4 RCTs and a number of patients to the tune of 132. The final recommendation is that the subgingival instrumentation should be performed with hand or powered or ultrasonic instruments alone or in combination. In other words, there is no difference in outcomes whether you're using hand instruments or ultrasonic instruments or a combination. So you cannot hereafter insist that we should only instrument using hand instrumentation when you have the newer ultrasonic instruments, which according to the available evidence provides the same level of healing or same level of clinical outcomes. So there is not, at the moment, there is no strong evidence to suggest that one type of instrument, the manual instrument, is higher or the ultrasonic instrument is higher. It is the choice of the clinician. It is the expertise of the clinician. He can use either ultrasonic instruments or hand instruments or a combination, because most of us are using a combination. In certain sites, we prefer hand instrument, and in certain situations, if we prefer ultrasonic instrument in the same patient. And this, again, this recommendation has a very strong backup with a grade A. Now, are treatment outcomes different when subgingival instrumentation is delivered quadrant-wise or multiple visits or as full mouth procedure within 24 hours? The supporting literature again in Suvan et al. And it included 8 RCTs and 212 patients. Now, this full mouth approach is a very popular thing in India, especially in postgraduate viva examinations or clinical examination. Many examiners will ask about full mouth disinfection. Our students are also very thrilled with this one single or full mouth procedure where you use a lot of chlorhexidine. The final recommendation here is subgingival instrumentation should be performed with either traditional quadrant-wise or full mouth delivery within 24 hours with a grade B recommendation. Or in other words, there is no difference at the moment to suggest that one technique is superior to other. If you are instrumenting in a quadrant-wise approach, 1 quadrant, 1 week, and you're completing the treatment in 1 month for that patient, no issues. Or if you're doing everything within a span of 24 hours, supra and subgingival instrumentation in all the quadrants, within a span of 22 hours in 2 sessions, or even a single session. It all depends upon the choice of the clinician, choice of the patient preferences. There is no evidence to suggest that one technique is superior to the other. At this moment, it will be interesting to see further the concept of one-stage approach of full mouth disinfection. The points in favor of full mouth disinfection is that the most subgingival species occupy the other oral niches, because you will have your oral microbiota. It is not as oral microbiome because it establishes its presence in all possible niches in the oral cavity, not only in the gingiva or in the periodontal pocket. You will see those organisms on the dorsum of the tongue, on the peritonsillar area, on the buccal mucosa, everywhere. So, and also there is possibility of recolonization from the untreated site to the treated site if you are resorting to a quadrant-wise approach. So there is possibility of recolonization, and of course there is the additional benefit of chlorhexidine that is in favor of the full mouth disinfection. But if you look at the original Quirinen paper in 1919, and you find that the patients were only 10. There were only 10 patients in that study. And among the 10 patients, only 5 patients were taken up for the test group and 5 patients in the control group. So 5 patients received full mouth disinfection and 5 patients received quadrant-wise scaling. And among the control group, 5 patients, 2 were smokers. So there is definitely, this is an underpowered study. By all means, by any means, is an underpowered study. And this is issue of statistical significance. Even though it is statistically significant, the issue is that whether it is clinically significant, because the outcomes were measured only after 1 to 2 months period. We know that the non-surgical therapy is now highly regarded as a therapy by itself. It has the potential to give very positive outcomes, but the outcomes should be measured little more later. That is minimum 3 to 6 months. And many papers have shown that the outcomes will only improve, and the improvement may happen up to 1 year. So it is not a good thing to evaluate the outcomes after 1 or 2 months, especially if you're performing non-surgical therapy, but the healing may continue. So finally, there won't be any difference between the 2 groups. And there is an RCT published by Graziani and colleagues in the Journal of Clinical Periodontics in 2015. It is an RCT. It included 38 perio patients. What they have compared is they have compared the full mouth scaling and rope planing versus quadrant-wise scaling and rope planing. So the test group, they took up the full mouth approach. The control group, they received quadrant-wise scaling. Outcomes were the inflammatory mediators, markers, the acute phase protein, CRP, interleukin-6 and TNF-alpha were assessed after 24 hours of the completion of scaling. And they have found that the full mouth group had a 3-time increase in the circulating acute phase response. So at this moment, it can be concluded that the full mouth disinfection protocol definitely triggers a 24-hour acute phase proteins. This may lead on to the systemic inflammatory response, which is maybe troublesome or detrimental to a group of patients, like patients who are risky for coronary artery disease or patients who are diabetic. So it should be with some caution that you should submit your patients for full mouth disinfection protocols, because there is this potential of triggering or a surge in the circulating cytokines 24 hours after the procedure. Many patients will complain of fever if you the very next day after the full mouth disinfection protocols. In some patients, it may be subsided as a fever. In some patients, it may go subclinical, but in some patients, it can be troublesome. So if you conclude, before concluding, we have this adjunctive therapy, because in step 2, that is the subgingival instrumentation, the adjunctive approaches has always been the spice of the step 2. And we have several approaches like lasers, like photodynamic therapy you employ along with scaling and rope planing. And we have many studies in India published in high impact journals, especially from Bangalore, several randomized control trials in which these adjunctive agents have been tried along with scaling and rope planing. The effort is to minimize the need for surgery in such patients. If you can add some adjunctive physical agent like laser or any chemical agent like statin or probiotics or subantimicrobial doxycycline or bisphosphonates. If you can add that in one group along with scaling and root planing, and if you can demonstrate that group had better outcomes in terms of scaling alone, then definitely that is going to be a benefit. So you had several studies, but at the moment, we'll take up these individual adjunctive agents one after another. And this first thing is regarding the adjunct use of laser and antimicrobial photodynamic therapy. The basis for the review or the guidance is the paper or systematic review by Salvi in 2019. Salvi has considered laser and antimicrobial photodynamic therapy as two separate focus questions. And in the laser query, they included 5 RCTs in 46 patients. And the recommendation is that we suggest not to use lasers as an adjunct to subgingival instrumentation. With regard to antimicrobial photodynamic therapy, there were 8 RCTs, but the outcome is the same. We suggest not to use adjunctive antimicrobial photodynamic therapy as an adjunct to subgingival instrumentation, and the grade of recommendation is a positive recommendation with a grade B. Now, what is the reason for such a recommendation? Because we know many of our colleagues are laser dentists, and many of our institutions offer laser-based protocols for managing periodontitis. Many clinics are offering, and many clinicians are offering laser as the only solution for periodontal management. And these guidelines have been passed in Germany. Germany, we have the Society of Dental Laser. Dental Laser Society is very active in Germany, but the German professional body also passed this recommendation because there is a lot of heterogeneity in the studies, a lot of heterogeneity in the available studies. The laser type employed, the wavelength of the laser employed, tip diameter, mode of perio treatment. And the new review, that is a 2019 Salvi review, only considered single applications of laser, and only they have considered randomized control trials with more than 6 months follow-up. That is maybe the reason why we don't have any strong evidence in favor of laser. But that doesn't mean that lasers are not effective or they are not ineffective, but the decision has to be made by the clinician. The patient can afford it. If they can ensure safety of laser use, then definitely there is no contraindication. But it cannot be given as a routine recommendation to all periodontitis patients because the evidence base is not that strong at the moment. Now, considering the adjunctive therapies, now we have, I've tried to put all these adjunctive therapies into one. Local statins, probiotics, doxycycline, bisphosphonates. What is common is that the recommendations does not suggest its use, or rather the recommendation is in a negative connotation. And for certain agents like statins or probiotics, statins or bisphosphonates, there is a strong recommendations not to use. But in case of probiotics or subantimicrobial doxycycline, the recommendation is B. Anyway, the recommendation is not in favor of these agents for routine use. Then comes the local drug delivery. The local drug delivery, we are very fond of this local drug delivery. There are several agents that are available in India. At the same time, there are certain agents which are not available in India. So it will be nice to look at these guidelines from an Indian perspective. This is very pleasing to us because the guidelines does not recommend the routine use of these local drug delivery agents. In fact, the recommendation, what they've graded is an open recommendation. That means that may be considered on a case by cases. If you feel that in one of your sites, for example, you have a patient after your non-surgical therapy, there is one single site that is non-responding. If that single site is not associated with any furcation or an infrabony defect that requires surgery, then you can consider applying this local drug delivery in this particular site. So the availability of local drug delivery agents, especially PerioChip and the Periostat, these agents are not available in India as far as I know. So there is no strong evidence base also to recommend their routine use. Then this is the important thing to consider, the use of adjunctive systemic antibiotics. Now we have the issue of this issue of the adjunctive systemic antibiotics. Systemic antibiotics have been misused and abused, especially since the COVID pandemic. Every COVID positive patient is asked to take a course of azithromycin, and we have this issue of antimicrobial resistance. And many countries have already started antimicrobial stewardship programs. This review by Tugels suggests that they have considered randomized controlled trials involving all types of periodontitis, including chronic periodontitis and aggressive periodontitis. When all the types of periodontitis put together and compared with scaling root planing alone and adjunctive antibiotics, the antibiotics offered only less than a millimeter, that is 0.45 millimeter. That is less than half a millimeter of additional PPD reduction. You know that even though it is statistically significant, how significant is it clinically? Less than half a millimeter more PPD reduction in a patient after giving a course of systemic antibiotics. It is the clinician's choice whether to use it or not. So regarding systemic antibiotics, there are two recommendations. First recommendation is a very strong recommendation to discouraging the routine use of antibiotic after NSPT. It's a very strong recommendation not to use systemic antibiotics routinely in your patients. And also there is another category of special group of patients called young patients with grade C disease. These young patients with grade C disease are our old aggressive periodontitis patients. So aggressive periodontitis patients, the clinicians can consider. But the recommendation is an open recommendation. The clinician may consider the use of systemic antibiotics in aggressive periodontitis patients, but it is not routinely recommended for all patients. Now to conclude the step 2 or the non-surgical phase, subgingival PM/PR is highly effective and strongly recommended. Step 2 and 2 may be done together if you feel so. Root surface intervention can be undertaken by hand instruments or powered instruments. There is no difference in outcome between the two. The one-stage full mouth approach definitely induces an acute phase response. The clinician should be aware of it. Adjunctive use of lasers currently lack sufficient evidence. That doesn't mean that lasers are not effective. Adjunctive host modulating agents currently lack sufficient evidence to support its routine use. And adjunctive local drug delivery of antibiotics like chlorhexidine chip or local drug delivery agents may be considered in local sites on a case-by-case basis, and systemic antibiotics should not be used routinely unless it is grade C periodontitis in young patients. Now moving on to step 3. Step 3, as I mentioned, will be undertaken after a re-evaluation after the non-surgical phase. Now what are the endpoints of treatment? What are the endpoints that you are looking at after your non-surgical therapy? Then the new endpoint is pocket closure. Pocket closure means periodontal pockets less than 4 millimeter that are not bleeding. So this is the new outcome or new endpoint of periodontal treatment. So all periodontal treatment should be aiming at this endpoint. So what you should attain is all your periodontal pockets should be less than 4 millimeters without bleeding. Some cases there will be deep pockets, and see what are the deep pockets, and are there any pockets which is more than 6 millimeter. They are more than 6 millimeter, you have another set of treatment for it. So these are the endpoints of therapy. And based on the endpoints, if the endpoints are achieved after step 2, there is no step 3, you will directly go to step 4, that is supportive periodontal care. If the endpoints are not reached after step 2, definitely you have to go to the third step. Now the issue of competence to perform periodontal surgery. Who can perform periodontal surgery? In India, we can translate the recommendations from the EFP to the Indian situation. We can say that anybody who is performing complex periodontal surgeries as part of periodontal therapy should have an additional training in the form of an MDS in periodontology for a period of 3 years to make him eligible, make him capable of doing surgical therapy for periodontitis. This is a legal thing. This is a regulatory thing. So here it becomes mandatory for anybody to perform periodontal surgery. You should have this additional training. Now, what are the prerequisites to perform periodontal surgery? You cannot perform periodontal surgery in every patient. The patient should ensure a good plaque control. The patient should be an engaging patient. Then who is an engaging patient? A patient who is demonstrating good plaque control, where the full mouth bleeding score or full mouth plaque score is less than 20%, that patient is a candidate for periodontal surgery. So this should be the target to be achieved before beginning periodontal therapy. Do a full mouth assessment of plaque and bleeding and see whether how many sites are bleeding, how many sites are having plaque score. So based on this, we'll determine the patient's eligible for surgery. At the same time, you have to look at the risk factors also. The risk factors like diabetes and smoking have to be under control. And there should be, of course, no medical contraindications for performing surgery. And if you're planning periodontal surgery in your patient, in addition to the original informed consent that you took for non-surgical therapy, you should get an additional consent for surgery. This is also very important. Now, what are the complex cases that require surgery? Now, the new guidelines document very clearly states that infrabony pockets, infrabony defects, and furcations are the indications for periodontal surgery. If you're doing periodontal surgery in a moderate pocket, 4 to 5 millimeter pocket with horizontal bone loss, then that may be deemed as over-treatment because the guidelines does not support doing periodontal surgery in a horizontal bone loss with 4 or 5 millimeter pocket as a first option. Now, looking at the rationale and the individual interventions, the rationale of step 3 therapy or surgical therapy is aimed at treating non-responding sites to the first 2 steps. The general guidelines are the pockets are in the range of 4 to 5, that is bleeding. The choice should be a repeat subgingival instrumentation rather than going in for surgery. So even if the patient has completed step 2, when the patient comes for step 3 after re-evaluation, the pockets in the range of 4 to 5 millimeters, that is moderately deep pockets. The first thing that you should consider is to do repeat subgingival instrumentation. And if the pockets are more than 6 millimeters, then definitely the consideration should be an access flap surgery. The access flap surgery may be done along with a regenerative surgery or may be combined with resective procedures. The evidence base for these guidelines is the systematic review by Sanchez in 2019. Now, it'll be interesting to look at the new benchmark for doing periodontal surgery. The new benchmark for doing periodontal surgery is PPD of 6 millimeters. This is the new critical probing pocket depth. Our students will be familiar with the Linde's recommendation of the critical probing depth that we have been following. But the new critical probing depth for periodontal surgery is 6 millimeters, irrespective of the anterior or the posterior sextans. If you are performing surgery in a pocket which is less than 6 millimeters and that is not associated with an infrabony defect or a furcation defect, then you may be questioned. So that may result in some clinical attachment loss. That may result in some loss of attachment. So you may be doing harm rather than good if you are resorting to surgery immediately after scaling and root planing in a moderately deep pocket. Now, what are these access flaps? Access flaps are conservative surgical procedures aimed at root surfaces to gain access to the root surface without removing significant amounts of soft tissue or hard tissue. These are the classification of the various access flap. It starts from the Kirkland's clavicular incision flap or the open flap debridement to the papilla preservation flap and its modifications and the recent minimally invasive techniques. When you look at the evolution of the flap technique is a pretty old technique. It has a long tradition, over a century since the technique, close to a century since the technique is introduced to the field of periodontology. The first technique to be introduced was in 1932-31 by Kirkland, the open flap debridement. Then came the Ramford and Nessels modified Whitman flap. Then came the game changer. The game changer was the papilla preservation flap introduced by Takei. And then the several modifications suggested by Cortellini and Tonetti to the modifications of the conventional papilla preservation flaps. And now we have, with the advent of microsurgery and magnification, now we have the minimally invasive or the MIS sort of techniques, single flap approaches, wherein we are trying to limit the invasion to the minimum. So the next question is which access flap. Now, having discussed, having known all the various access flaps, is there any difference between the flap techniques in terms of superior outcomes? So the recommendation is that at the moment, with the available evidence, it's an open recommendation. There is insufficient evidence to show that one flap technique is superior to another when employed in deep pockets. That doesn't mean that you should only employ one type of flap surgery. You should take up individual types of procedures based on the patient's requirements, based on your expertise, and based on the patient's preferences. But there is no strong evidence to suggest that one technique is superior to the other. What is effective? How effective is a resective surgery compared to access surgery? Resective surgery have been very popular in the olden days. Many of our old generation of periodontists have been performing this, and they have actually met with a lot of success. Resective approaches are now recommended only preferably in the posterior quadrants, because there is always this issue of gingival recession associated with resective surgeries. And resective surgeries aims at pocket elimination. And this systematic review with Pollack, which included 9 RCTs. Of course, there was a high risk of bias. That is why the recommendation is an open recommendation. What we can say at the moment is resective surgeries are highly effective, especially in deep pockets. But the thing is that they are associated with potential of gingival recession. Now, what is the adequate management for deep periodontal pockets associated with intra-bony defects? Now, we have clear recommendations for periodontal regenerative surgery, thanks to the new document, thanks to the new evidence-based guidelines. We have a very strong systematic review, high-quality systematic review by Nibali, 2019, which included 22 randomized controlled trials and close to 1,000 patients. The data meta-analysis suggested that regenerative periodontal therapy is recommended strongly in infrabony defects deeper than 3 millimeters. So what you have to do is, once you have an infrabony defect, you have to measure the depth of the infrabony defect. That should be done either before surgery by means of transclavicular probing or by means of any investigation, or at the time of surgery as an intraoperative assessment. After you have raised the flap, do an intraoperative assessment of the depth of the infrabony defect. If it is deeper than 3 millimeters, definitely regenerative therapy is the recommendation. And what are the points in favor of regenerative therapy in infrabony defects according to the Nibali's paper? Nibali concludes that there is an additional clinical attachment gain of 1.34 millimeters and a PP reduction of similar PP reduction of 1.24 millimeters compared to OFT, that is open flap debridement. That means there is an 80% improvement compared to OFT when you perform periodontal regenerative surgery in infrabony defects. And of course, you are minimizing the risk of tooth loss in such patients. And even if the regenerative therapy may be initially expensive, but you can justify in that you are actually reducing the risk of tooth loss in that patient. We all know that tooth replacement is such an expensive affair. So if you can minimize tooth loss, it's always better. So the bottom line regarding regenerative surgery is that all infrabony defects that are deeper than 3 millimeters should be taken up as for periodontal regenerative surgery, because we have a very strong evidence base for better outcomes with regenerative therapy in infrabony defects. Now let us consider the choice of biomaterial. The choice, we have a plethora of agents that are available in India. We still don't have many agents that are being introduced maybe 30 years before to the rest of the world. You take, for example, EMD. EMD has been in use for over 30 years, but we still don't have EMD in India. And similarly, there are other agents which are not available in India. Maybe growth factors, infuse, all these things are not available in India. So we have to consider the availability of these agents when you consider the choice of biomaterial. You have to consider the cost of these biomaterials, the expertise, whether the clinician is capable of doing a GTR procedure. Does he have that expertise to do it? Also, you should consider the defect configuration, whether it is a contained defect or a non-contained defect, how many walls the defect has. Is it a 3-wall defect? Then well, we can proceed with regeneration. If it is a 2-wall defect, if you can do a GTR, it is good. But if it is a 1-wall defect, which is non-contained, then definitely there will be favorable outcomes. Then you can also consider the autologous materials like PRF and other combinations which are available with you. Now, regarding the choice of regenerative biomaterials, these are the conclusions from the Nibali's paper. I have not totally avoided EMD from the presentation because as far as I know, the EMD is not available in India. There is no point in mentioning about the advantage of EMD to an Indian population, the Indian group of professionals. So right now, from an Indian point of view, if you ask me what are the biomaterials of choice, I would say that you can employ GTR and with a resorbable membrane, because there is no difference between resorbable or non-resorbable membrane in terms of healing outcomes. And moreover, there is this potential of membrane exposure with non-resorbable membranes. So you have to be very careful in employing non-resorbable membranes in periodontal defects, whereas non-resorbable membranes are highly beneficial for peri-implant defects. So a non-resorbable membrane should be reserved for large peri-implant defects or ridge augmentation defects where you are doing GBR rather than GTR. For GTR, where the defects are small, where the soft tissue availability to cover the graft is less, there is always this potential for a membrane exposure. Membrane exposure is actually a negative outcome. So which is the best flap design for regenerative therapy? There is strong recommendation for papilla preservation flaps wherever it is possible. So wherever possible, if you're planning a regenerative therapy, employ one type of a papilla preservation flap. And Graziani's paper in 2012 have compared the outcomes between minimally invasive flaps and conventional flaps. And he has shown that minimally invasive flaps, there is a clear trend towards minimally invasive flaps and regenerative therapy. So whenever possible, if you have the expertise, if you have magnification, if you have the microsurgical instruments, if you have the clinical situation in favor of doing a minimally invasive flap, always go for a minimally invasive flap as a first choice flap for periodontal regeneration. Or if it is not there, go for some kind of a papilla preservation flap. The least thing should be the clavicular incision flap, because and you should never consider modified man flap as your flap choice for periodontal regeneration, because even if only 0.5 to 1 millimeter of tissue is removed, cuff is removed, you are still removing some tissue and you're also thinning the flap. But thinning the flap is not at all indicated for periodontal regenerative procedures. We should have a thick keratinized flap to cover the graft. Now moving on to the furcations, management of furcations and the guidelines in favor of furcation management. The classification that the guideline considers is the Ham et al. Classification for obvious reasons, because in Glickman's classification, we know they are between grade 3 and grade 4, they are considering the recession, soft tissue component, which actually is complicating the Glickman's classification. So this is a horizontal classification. Ham et al. Classification is a horizontal classification wherein the class 1 is a beginning of involvement, less than 1/3 of the horizontal component is affected. Class 2 is a cul-de-sac where there is no through and through, and class 3 is a complete through and through defect in the interradicular area. Now there is a clear increase in the number of implants being placed over these years. This paper in 2018 from the Journal of Dental Research suggests that there is a steady increase in the number of implant surgeries over these years, and the implant industry is expected to grow leaps and bounds in the next decade. And the most frequent indication for implant placement is single tooth grafts rather than full mouth rehabilitation. So 52.8% of the time when an implant is used, it was used for single tooth replacements, and more than half of the times it was used to replace a mandibular molar. So it is interesting to read this paper along with the previous paper, that this is again a systematic review and meta-analysis by Nibali. He has considered the tooth loss in molars and the reasons for tooth loss in molars in patients undergoing supportive periodontal care. He has shown that presence of furcations doubles the risk for molar loss after 10 to 15 years. 10 to 15 years is a longer period. So in other words, what you can say is that Furcation involved teeth, they respond very favorably to periodontal therapy, especially even the class 3 furcation, where there's a through and through defect. They also response very favorably to the periodontal therapy, and periodontal therapy should be considered. This is our next recommendation. What is the adequate management of molars with class 2 and class 3 furcation involvement and resolvent pockets? So class 3 or class 2 furcation involvement is not an indication for extraction. This is a very strong recommendation that you should not extract teeth just for the sake that they are affected by furcations. The supporting literature, 2 papers they have considered, 2 systematic reviews, one by Jepson and another by Domish. The strong recommendation is that furcation involved teeth, even it is a grade 3 furcation, class 3 furcation, where there is a total bone loss, you should not consider extraction as a first choice treatment. Rather, they should be subjected to routine periodontal therapy. Now, what is the adequate management? Now we will see the individual recommendations for furcation. What is the adequate management for class 2 mandibular molar furcation? We know class 2 mandibular molar furcation, especially the buccal furcation involvement, is very, very favorable for regenerative therapy. And there is a strong recommendation when you have a class 2 furcation involvement in a lower molar, it is suggested that you should always do a regenerative therapy because there is a strong recommendation for success. In case of maxillary buccal class 2, the recommendation is positive, but it is not as strong as a mandibular molar. So they suggest that regenerative therapy may be used for buccal class 2 furcations. Now, these are the endpoints of furcation management. Whenever we do a therapy for furcation, we are aiming at either of the 3 outcomes. The ideal outcome is furcation closure or complete closure of the furcation. The next outcome is whether are you able to convert the furcation, whether are you able to convert class 3 to class 2 or class 2 to class 1. Or even if it is a class 2, even if you are not able to convert, are you able to bring about some improvement in furcation? So having considered all the treatment outcomes, it can be stated that the combination therapy, that means GTR plus bone grafts, offer maximum potential for furcation closure when compared to EMD or bone grafts or GTR alone or various kinds of bone grafts. All these biomaterials put together, the systematic review by Jepson concludes that the combination therapy in the form of GTR and a bone graft offers the most positive or superior outcomes, and there is 60% potential for furcation closure when you employ this combination therapy. Now, what are the appropriate regenerative biomaterials for furcation therapy? So this is the original recommendation by the international group, that is EMD GTR. But when you look at the Indian perspective or the Indian version of the choice of biomaterial, I can tell you that GTR with a resorbable membrane, because it is freely available, resorbable membrane and a bovine bone matrix, that is also freely available. A xenograft, any xenograft with a resorbable membrane should be the choice of biomaterial for a class 2 lower furcation involvement or an upper furcation involvement. Because EMD is not in the market, and we can say that regenerative periodontal therapy is less expensive than extracting and placing an implant. So maxillary interproximal class 2 furcations. What is the option for interproximal or class 2 furcations in maxilla? Recommendation is that it's an open recommendation. There is no recommendation for any regenerative therapy here. So you can employ either non-surgical therapy, open flap debridement, regenerative or resective therapy. In terms of the various healing outcomes as discussed in the supporting evidence, they have taken 3 systematic reviews. One by Huyenba et al. 2009 is an old review, and the recent reviews by Romish. They suggest that there is no superiority for one technique over the other for management of maxillary interproximal class 2 furcations. Now, this is from an unpublished upcoming paper by Friedman that shows that when you consider the predictability of regenerative therapy in furcations, you have a better prospect for mandibular molars. Mandibular grade 2 furcations always have a better prognosis than a maxillary molar with a buccal or buccal grade 2. Then the interproximal percussions will have a little more less favorable response to periodontal regenerative therapy. Now coming to the mandibular and maxillary class 3 percussions. Class 3 percussions we know are through and through bone loss. It's an open recommendation and regenerative therapy is not at all in the list. All you can do is you can either resort to non-surgical therapy, open flap debridement, tunneling, and the resective approaches. This is can be taken up as an individual case-by-case basis. What is the requirement for your patient? What are the characteristics of the percussion involvement in your particular patient? Based on that, you can consider either repeat non-surgical therapy, open flap debridement, tunneling, or root resection. But always there is the possibility of root surface caries and all those things that should be mentioned to the patient if you are performing a tunneling procedure. Now we come to the last step or step 4 the supportive periodontal care. Now after the active phase of therapy, that after non-surgical or surgical therapy, once the outcomes have been reached, the endpoints have been attained, you can categorize these patients into 2 groups. This is according to the new classification. First group is the reduced healthy periodontium. That means you have attained all the pockets below 4 millimeters. You have reduced the pocket below 4 meters. Or in other words, you have achieved pocket closure. But the bleeding also you have achieved below 10%. That means there is restoration of health. We call such patients are stable patients. But in such stable patients also, there is this risk of recurrence because once a periodontitis patient for life. The second category is a patient in which you have attained pocket closure, but the bleeding point probing is more than 10%. That means there is some amount of gingival inflammation present in the soft tissues, but the pockets are within controllable limits, less than 4 millimeter. In such patients, there is always a risk of progression of disease. So taking into consideration, after the active phase of therapy, patient should definitely undergo the supportive periodontal care. The first question that comes to our mind is the interval. What is a supportive periodontal therapy intervals? Now, the available evidence for all of us are the Merin's classification. Merin's classification, you classify patients into class A, class B, and class 3. And there are a lot of parameters. You don't even remember those parameters. It's very difficult to apply those parameters in a patient case. So it becomes very ambiguous. There is a lot of lack of clarity in terms of the intervals, the SPT intervals, whether to recall the patient after 1 month, recall the patient after 3 months, or recall the patient after 6 months. So what the recommendation then suggests is the supportive periodontal therapy visits should range between 3 to 12 months intervals, and the frequency should be based on the individual patient's risk profile and the periodontal conditions that you have achieved after their therapy. Though the patient's risk becomes very important. What is the risk profile of your particular patient? And based on that, you decide the SPT interval. How will you determine the patient's risk? We all know about the PRA or the periodontal risk assessment algorithm suggested by Lang and Tonetti in the year 2003. I think initially they came out this publication in 2003. And based on that, the University of Bern in Switzerland has developed an online algorithm which is freely available in the internet. Anybody can utilize this periodontal risk assessment for your individual patients. You have to input the details what they are asking for to obtain a spider chart for your patient, like the bleeding and probing percentage, the pockets which are present after active therapy, how number of teeth lost, if there are any systemic disease, environmental factors. You put all your patient's individual risk factors into this algorithm, and the algorithm will generate a spider chart for you. Based on the spider chart, you determine the risk profile of the patient, and accordingly, you determine the SPT interval. Now we shall see 2 patient types here. The case 1 is a patient with low periodontal risk. As you can see in the spider chart, the spider chart is very small one. The diagram is small. So the patient is having obviously a low risk. The patient is having a low risk. The recall interval can be every 12 months. That you need to see the patient only every year. Suppose the patient's risk is very low. But in case of a case 2, where the risk is little more higher, where the diagram, the area of the spider diagram is more when compared to case 1, that obviously shows that the patient is a high-risk patient. For high-risk patients, you have to recall them after every 3 months. The next question is the adherence to supportive periodontal care. We all know that patients who fail to come back for SPT reviews will definitely have a poor prognosis. That has to be documented in your clinical case records. The patient is not following SPT intervals. You should mention that. You have to mention this beforehand, before you're starting the therapy, that you have to come for follow-ups and you have to adhere to our protocol, because there is strong evidence to say that. There is a strong recommendation, grade A recommendations to say that adherence to SPT visits should be strongly promoted to sustain the results that you have obtained with the active phases of therapy. Now, another important issue is the choice of material, choice of toothbrush. Whether can you use a manual toothbrush or is an electric toothbrush needed? Or what is there an advantage for electric toothbrushes over conventional brushes? And also regarding the choice of the interdental cleaning aid. Now, it is disappointing to say that these interdental cleaning aids are not freely available in our country. I think ISP, our president is here, secretary is here. I think ISP should take this matter. We have to, I think, better to discuss with the pharmaceutical companies and manufacturers and try to make it available across the country, especially the complete range of interdental brushes, because there are various sizes of brushes that are available, sizes ranging from 0 to number 8. And I have not seen the entire range of interdental brushes in my career that is available in India, but it's available elsewhere in the world. Actually, the choice of interdental aid is dictated by the interdental space dimension. So patient's ability to perform oral hygiene. If you are suggesting an interdental brush to a patient, and if that interdental brush doesn't fit the interdental space of that particular patient, then this is not going to work. So you have to have a handful of interdental brushes according to different sizes for different sites, because the point of selection is that you should select the most fitting interdental brush. The most snugly fitting interdental brush should be selected for a particular site. Then only the success of therapy, because this is we are going to fight periodontal disease with this interdental brush rather than the chlorhexidine or any other mouth rinse. And what is the value of dental flossing in periodontal maintenance patients? It's very interesting to say that flossing is not the first choice of interdental cleaning aid in a patient with periodontitis. Of course, flossing is the first choice interdental aid in a periodontally healthy patient. But in a patient with periodontitis, there will be some interdental recession and there will be some opening of these embrasures. In such cases, this floss will not work. What works is the interdental brush. So interdental brush should be the first choice in the interdental aid for all your periodontitis patients. And now another question is, which toothpaste is better for gingival inflammation? Because anyway, we'll be prescribing a toothpaste for their self-care, and which toothpaste is better. There is no strong evidence to suggest any particular toothbrush. This is a European recommendation. What they have given is the stannous fluoride toothpaste are better over toothpaste containing chlorhexidine or other agents. And I don't think we have a toothpaste that contains chlorhexidine available in India. I'm not aware, but definitely we have toothpaste that contains stannous fluoride, and this stannous fluoride will definitely help the patient in minimizing the root surface sensitivity that all our periodontitis patients develop following active periodontal therapy. So it becomes a sensible thing to prescribe all our periodontitis patients throughout the phases of active therapy and after a toothpaste that contains stannous fluoride, because it definitely is going to minimize the gingival inflammation, and also it will minimize or treat the dentinal hypersensitivity. Now, what is the antiseptic? The most popular question, what is the antiseptic the most effective in mouth rinses? According to the evidence by Figueroa, the systematic review by Figueroa, which is available in JCP, chlorhexidine is not the preferred antiseptic. There are obvious reasons for chlorhexidine because there are side effects. There is a case of even anaphylaxis reported. The patient actually died out of hypersensitivity to chlorhexidine. And there are other, the issue of bacterial resistance is there. So essential oils without alcohol is the first choice ingredient as an antiseptic in the mouthwash. Now we have coming to the end of the presentation. We have gone through all the relevant recommendations which are relevant from an Indian point of view, which is interesting to an Indian periodontist. Now to summarize, we shall see the flow chart given by BSP regarding the guidelines. The first thing is the diagnosis. Step 0, you diagnose the patient as whether the patient is having gingivitis or periodontitis. The patient is having periodontitis, see how many teeth are having poor prognosis or unsavable teeth. You extract all those grade 3 mobile unsalvageable teeth. Then you initiate step 1. Step 1 means the supragingival PMPR, supragingival plaque control. At the same time, you initiate more instruction and motivation, and also you look at the risk factor control. Ask the patient to quit smoking or reduce the number of cigarettes. We check their diabetic status and try to bring it below 7%. Then you reevaluate if you have achieved the outcomes, that is less than 4 millimeter pockets without bleeding is already achieved. You can directly go to step 4. If there are certain residual sites, deep pockets, more than 4 millimeter that bleeds, then you initiate the step 2 therapy. Step 2 therapy is a subgingival instrumentation wherein you instrument the root surface in those particular areas where there are deep pockets under local anesthesia. And if the clinician wish to perform it by hand instruments or ultrasonic instrument, it is his choice. And he can employ a cotton device approach or a full mouth approach. It is again his choice. He can employ adjunctive agents as and when needed. He can include lasers or any adjunctive agents like phosphomodulating agents, but there is no strong evidence backing for the use of these agents. Then after step 2, the non-surgical phase, you reevaluate after 3 months. This is very important. The reevaluation is after 3 months, not after 4 weeks or 6 weeks. Most of our students learn that the reevaluation should be done after 4 to 6 weeks. That is not the thing. Reevaluation should be done after 3 months. But you can recall the patient in between. That doesn't mean that you should not see the patient in between. You should see the patient to confirm whether they are following your instructions, they are doing good plaque control. But the re-evaluation for the need for further therapy should be made only after a minimum period of 3 months. And if there are still non-responding sites, there are deep pockets more than 6 millimeters with infrabony defects or furcations, you can employ access therapy or regenerative therapy or resective therapy based on the guidelines. And again, you go back to re-evaluation and see whether it is stable. Once the patient has achieved stability, you move to the step 4. Now, so far we have discussed about the management of stage 1 to 3 periodontitis. Now, the recent workshop by EFP has also formulated guidelines for management of stage 4 periodontitis, that is advanced periodontitis. And hopefully, if time permits, we'll try to discuss that sometime later. Now it's the time for acknowledgements. I have heavily relied on these stalwarts, Ian Chappell, Moritz Kepschul, Nikos Donos, and Nicola West, who are actually the main pillars behind the guideline development group for the EFP as well as for the BSP. I've taken a lot of information from their works, their presentations, and there are no words to express my gratitude to this gentleman. As Dr. Anirban mentioned, the dawn of ISP, arguably the most popular periodontist in the country, Dr. Biju Thomas sir. It was because of his enthusiasm that this program was planned and executed. And a big thank you to the team, Department of Periodontics, headed by Dr. Amita, Dr. Rahul, also BCT, Memorial Institute of Dental Sciences, and a very big thank you. I'm really honored to have made this presentation on behalf of ISP as the first ever program for 2022 as part of this professional enrichment program. And you have a very fantastic lecture. You're all awaiting for the lecture by Ashish Kumar regarding the classification merits and demerits. But before that, let me express my sincere gratitude to one and all of you for patiently listening to this webinar on a Monday morning, staying out of your busy schedule. Thank you once again. Thank you.
Thank you, Dr. Baiju, for that comprehensive coverage of the S3 level guidelines. We have talked about the strengths of recommendation, the strengths of consensus, and the stepwise approach to periodontal therapy. I'm sure it has been very beneficial for all of us, especially for our budding periodontists, the postgraduate students. And there will be definitely, as I told, we'll take up the discussion at the end. Now, I know Baiju for the last 20-25 years as a periodontist. Without any hesitation, I will say is one of the finest academicians I've seen from the state of Kerala. Now, just project the certificate Baiju from a small token of thanks from our side. I know this is not enough for the effort you have put in for this lecture. Definitely, you need a much bigger appreciation from our side, but we'll be formally sending you the certificate later. Now, we are monitoring the chat box. The questions will be taken up once Dr. Ashish Kumar's lecture gets over. Now, coming on to the second speaker of the day, Dr. Baiju.
Yes,
we are moving on to the second lecture now.
Sure, sir. Sure.
And we'll be coming to the questions at the end of the second lecture. Huh?
Fine.
Ashish Kumar, are you online? Ashish Kumar?
Yes, sir. I'm online, sir.
So it is my pleasure to introduce Dr. Ashish Kumar, the editor of the Indian Society of Journal of Indian Society of Periodontology. 2 days back, when I asked Dr. Ashish Kumar for his CV, he just gave me 2 lines that he's an alumnus of Bapuji Dental College, Davangere, and currently the professor and head at Regional Institute of Medical Science, Imphal. But all of us ISPNs especially know he's much more than that. In fact, I will say he's one of the pillars of strength of the Indian Society of Periodontology. Last 4-5 years, he has single-handedly shouldered the responsibility of taking our journal to greater heights. And as we older people are slowly fading out, I'm sure people like Ashish Kumar and all are going to be the pillars of strength and probably the heavyweights of ISP in the times to come in future. I'm sure, Ashish, you have a great responsibility in future in our Indian Society of Periodontology also. Over to you, Dr. Ashish.
Thank you, sir. Is my screen visible, sir?
Yes, Ashish, your screen is visible.
Thank you, sir. Thank you for a wonderful introduction. I start my presentation with mentioning thanks. I speak with thanks to God, my mother, and my teachers at Bapuji Dental College and Hospital, Davangere, and remembering my sir, Dr. D.S. Mehta, sir, whom we lost recently, but whatever perio I know of, I have learned under him and all the teachers at Bapuji Dental College, and I will always remain indebted to them for giving me the knowledge and information about perio, and I stand here because of their blessings. I would like to thank everyone at AB Shetty, especially Biju sir, for having considered me for this platform, and Amita Ramesh ma'am, principal sir, for considering me good enough to speak on this platform. I speak from Dental College, Regional Institute of Medical Sciences, Imphal, Manipur. Manipur is, when many people get confused with Manipal, it is Manipur, the northeast of India. These are my dear colleagues who work with me in our department, and the topic, as told to me, was merits and demerits of 2017 classification. Here, I would like to tell you that in this presentation, with the limitation of time, I have only included the major things, the most common things which we come across and which we discuss in this class, in this presentation. And this presentation is not on classification per se, but only on the merits and demerits of the classification. Now, as everyone knows, the classification is basically a systemic arrangement of similar entities on the basis of certain differing characteristics. Now, there was, the proceedings of World Workshop in 2017, and this classification came on to, was introduced in Europerio on 21st June 2018 in Amsterdam. These were the people who were basically involved from American Academy of Periodontology and European Federation of Periodontology, who were, the base or the main people behind this classification. And this was the classification which was introduced, and basically the thing was that they had classified periodontal diseases into main 4 categories, which was periodontal health, periodontitis, other conditions affecting periodontium, and the new category which was added in this classification for first time was peri-implant diseases and conditions. Now, the merits, we will go on to the merits first. Now, there was new evidence which was looked at when they started, this classification. And the first thing which they looked at was that the microbial dysbiosis was coming into picture, wherein it was, from earlier consideration that a biofilm was necessary prerequisite. That was there, but it was now coming into picture that it's insufficient to cause the disease. Then there was a hyperinflammatory response, which was considered to be almost 80% risk of causing a periodontal damage. And then the precision medicine coming into play, where it was considered that the diagnosis has to be individualized. So these were the considerations wherein a new classification which was based on this precision medicine was the key. Now, the evidence which was coming into play was there was whether the biologic phenotype matches the clinical phenotype or not. Now, clinical phenotype, for example, what they were trying to look at is, does the classification which we were utilizing, does it have a biological basis or not? Now, this study by Scott, wherein they compared the gingivitis with normal patients in a split mouse study, and they were seeing the biomarker amounts and the concentration in patients with comparing a gingivitis versus normal. They could see that the clinical phenotype and biologic phenotype could be matched, and they found that it was substance P which was making a difference, and which could be the total amount in concentration and total amount of substance P at gingivitis sites could be identified, or could be the earlier marker of gingivitis, and the amount of substance P could discriminate between healthy tissues and tissues which had gingivitis. And all these interleukin-1 beta were would come into picture later on. So they could clearly say that the biologically and clinically, they could match this profile for gingivitis, which could be used for a classification system. But this could not be done for periodontitis. Then there were, transcriptome studies. The transcriptome study is basically a study of RNAs which are formed in response to the condition, for example, local conditions, disease, anything, and which is a very short-lived, process. You read those RNAs, and you could help in diagnosing or help in various studies. Now, in this, what they did was, this is a transcriptome study where they took 2 categories of patients on the basis of the 1999 classification. One group of patients was chronic periodontitis, and the other patient was aggressive periodontitis, strictly according to 1999 classification. And their RNA biopsies and RNA transcriptome studies were done. Now, they wanted to see whether the RNA studies from chronic and aggressive periodontitis, on seeing do the transcriptomes also get divided into aggressive and chronic periodontitis, but the results were startling. Now, if you see what they saw, the clusters of RNA did not align with the currently accepted classification or now previously accepted classification of chronic periodontitis and aggressive. Now, why current? Because this study was done before the 2017 classification came in. So it did not, those RNAs from the group of chronic periodontitis and aggressive periodontitis did not adhere to the classification of CP and AGP, but the clusters were aggregated on the basis of extent and severity of periodontitis, the intensity of serum antibody response, and level of subgingival colonization. So the baseline was that the clinical phenotype of localized and aggressive, localized and generalized periodontitis, as well as of chronic periodontitis, did not match the biologic phenotype. That means on the basis of clinical phenotype, what we were dividing as per 99 classification did not have any biologic basis for that. So you had a new understanding of pathogenesis coming in. You had a new model of periodontal pathogenesis, which was introduced after 99 classification. Earlier, during 1970s and 80s, healthy condition meant that complete absence of inflammatory, infiltrate and gingival and plaque indices were considered to be zero. Initial model said as soon as you had bacterial plaque and calculus formation and you had, this was the pathogenesis model. Then came in this model in 2007 by Page and Conman, where again, presence of microbial challenge was considered to be a state of, disease which had started. But now, after 1999, you had symbiosis and dysbiosis coming in, wherein, symbiosis was a state of somehow mutual adjustment to some amount of microorganisms present in the mouth, still be considered to be healthy. And you had this new model which was presented there. It said that low biomass was considered normal to be considered to be, in a state of clinical health. And when it went to gingivitis, they said it was incipient diabetes. Now, a non-susceptible patient was considered to be gingivitis, and it will not progress beyond. So that means still in the case, what is important here is to note that health was not absolute absence of microbiology, microbiota, and the periodontitis of frank dysbiosis. Now, what is important here is that health was not absolute absence of microorganisms in the mouth. It was now being considered that a low biomass could be considered normal for you to consider the oral cavity or periodontium or periodontal status to be healthy. Now, we also need to understand that, every case definition has to be given. The case definition is basically, the features which you divide individuals on the basis of causes, prognosis, and response to treatment, which is a case definition. Now, without a case definition, no classification is possible. The classification is used to classify those clinical conditions, and the diagnosis which you give on the basis of classification is used to guide the treatment. So that means any classification has to have a case definition. Now, if you go back to 99 and other classifications, you will not find a very clear-cut case definition. So this was the first thing, which advantage of this classification was that you find in every group. Now, you had 4 work groups as per the 4 categories of classification. Work group 1, which was working on health and gingival conditions, they gave a clear-cut case definition of what is plaque-induced gingivitis, diagnostic criteria. Work group 2 was working on periodontitis. They gave clear-cut, framework and new classification and case definition. That is, how exactly, on what basis quantitatively you could divide a case or call a case as a periodontitis or gingivitis. So every group had clear-cut case definitions to have a clear-cut definition. Now, earlier you would have periodontitis, you did not have any, quantitative clear-cut definition. What would you call a gingivitis case? What would you call a periodontitis case? So similarly, in both group 4, they had a clear-cut definition for peri-implant health, mucositis, and implantitis. So these were the one of the best things which has happened in this classification. The next best thing which has happened in this classification is the introduction of periodontal health. Now, practically speaking, there were no studies which defined periodontal health. Now, you obviously require periodontal health to be defined at a histological level as well as a clinical level, because you want a preventive starting point. Now, if a patient comes to you, whether you really require a treatment for that or not, you want to define that. And after you have done a treatment, what is the therapeutic endpoint? Do you achieve health or not? there were no clear-cut quantitative guidelines which could define what is periodontal health. So this was the first time in 130 or 125 years of history of the classifications of periodontal diseases, you find a periodontal health was defined clearly. Now, in this paper, when they started working on the best, they wanted to define what is the definition of health, what is the difference, does the pristine periodontal health, which we generally read and see that, you find pristine in our textbooks when we were, reading periodontology was said to be a state where you have complete absence of microbiota, and it is generally seen notobiotic anemia. So they wanted to see, does the pristine periodontal health exist? What is the difference between clinical and pristine? So these were very clearly defined in this classification. Now, they took, the best way to define health was, because it was being done for first time, the health of, the WHO definition of health was the baseline to define. So on the basis of, if you take that definition of health as a state of complete physical, mental, and social well-being, and if you define periodontal health on the basis, they found that this definition was very complex and it was not an objective definition to use. So a definite objective definition was required so that it could be used clinically. Now, as I said earlier, that during 1970s and 80s, healthy condition was called as homeostasis, and it was considered to be gingival and plaque index to be 0 and complete absence of inflammatory infiltrate. And that was the histologic evidence. Now, what they wanted to see was that pristine health, does it really exist in clinical conditions? If it exists, it has to be, in 95% of population, because medicine says that a condition is considered to be normal if it is, available in almost 95% of people. So that they wanted to see, does pristine health, if it is to be considered normal, exist in 95% of population? But the results, what they showed was almost 95% of adults have one or more bleeding points in their mouth. Thereby saying that health, the conclusion they came to was health needs to accept some localized sites of mild inflammation, and pristine health is just unlikely and exceptional, largely limited to textbooks, that is in less than 5% of people. And therefore, they said it is not possible to have pristine health, and the term adapted and accepted in this classification was clinically healthy. Now, biology of clinical health was that they said that it is basically associated with a little bit of inflammatory infiltrate, which is considered to be normal, and a host response, which is consistent with homeostasis. Now, as per this classification from 80s and 90s to this point, the homeostasis, which was considered to be total absence of infiltrate and microbiota, had come, homeostasis has become a little bit of inflammatory infiltrate, which is considered normal, and a host response. That means what they were saying was the normal small amount of PMN which is present in the tissues in a healthy state is considered to be physiological and is for surveillance to keep the tissue in a healthy state, and is not considered to be pathological as it was considered earlier. So this is where the new pathogenesis model came into was being utilized, and they said clinical health is a presence of small amount of biomass which could be considered to be physiological, and is kind of a surveillance which PMNs give to the tissue to be maintained in a state of health. So then came the question: do you have inflammation which is present and which is compatible with health? Now they said that for this example, this is from again one of the presentations of EFP, where they showed that if you see in the lower anterior slight glazing and inflammation, so they said this is how clinical health could look like. There's a difference in the site of inflammation to the case of gingival inflammation. Case and site has to be separated. So you could have a case where one or two sites or few sites could have inflammation. Still, you could call those cases healthy. So they defined the definition of healthy in this classification came up, where they said that clinical periodontal inflammation is absent or very significantly reduced inflammation in an intact periodontium or maybe in a reduced periodontium. So now next question which they addressed in this classification, which is good, which is one of the good parts of this was how would you assess that clinical periodontal health? They said absence or low levels and the clinical indicator would be only bleeding on probing. Okay, that is to be used. Now they said that it is the best parameter. Now they have clearly defined in this classification that the parameter to define health for gingivitis is only bleeding on probing. Best parameter to monitor health and inflammation in gingival tissues. The next question they said, they also answered that why BOP is to be used, because BOP may not have positive predictive value. Means presence of BOP may not tell you whether a disease is there or not, but absence, that is the negative predictive value. If BOP is not there, it is the negative predictive that the patient will not have a disease or inflammation is very high. So it means presence may not tell you anything, but absence definitely tells you that patient does not have periodontal disease. So the BOP was a very good predictor of your absence of disease. Secondly, another thing which they very clearly clarified and good thing is that PPD alone or CAL cannot be used as evidence for gingival health of disease. BOP along with PPD and CAL has to be used to define. So that means thereby telling that BOP is the thing which is advanced, which you have to keep in mind, which is very, very clearly been mentioned in this classification. The next thing which they talked about and which was good is, where do you elicit BOP from? Normally, when we were studying, we were always told that BOP has to be elicited from sulcular epithelium, but we tend to probe the base of the sulcus and base of the pocket. We normally don't, use our probe on the, sulcular epithelium to elicit. Now, question was, what they said was there is no consensus on report that which is a better method to elicit bleeding. But what they also said that it is always better to use the method of probing the base of the pocket, because we are not trained to elicit bleeding from sulcular epithelium. So we are trained to probe the sulcus in our colleges. Also, when you probe sulcus, you get assessment of CAL and PD also, whereas which you will not get when you try to elicit bleeding from the circular epithelium margins, which you cannot achieve. So you are having two things. You are trained to do a probing of the sulcus depth. You also get to know CAL, PD. Then you also do a part of CPIT. And secondly, BOP also has advantage that it is correlated with patient-related symptoms. Now, most of the patients, when they come to you, they generally say, it is bleeding. The bleeding started coming. It bleeds off and on. It bleeds while brushing. So when bleeding stops, it also helps in patient also seeing that his health is being maintained. So these were the practical considerations which were taken into, and it was said that BOP from base of sulcus should be the area where you basically try to see whether it is health or not, and you to elicit. Then they also said that although you have manual and automated probes, but still there's no evidence that automated probes are better. They said the manual probe is always good and is the right choice to use to determine health or gingivitis. Although they have given the factors which affect probing and designs in a standardized design, but still manual probe as per their definition remains the best thing to diagnose health and gingivitis. Now in this, so the diagnosis of health, what they gave was the pocket depth is less than 3 mm and bleeding on probing less than 10%. That means if you have certain sites of bleeding up to 10%, they are considered to be healthy. Anything more than 10% would be called gingivitis if the pocket depth is less than 3 mm. Now, there are two circles which you find here, gingivitis and gingival inflammation. Now, once you have periodontitis, as per new classification, they say the patient once has a periodontitis, he remains the patient for periodontitis. That means after a patient has been treated for periodontitis, if he has inflammation again, you cannot call it as a case of gingivitis after periodontitis because the diagnosis of periodontitis has already been given. So in such a case, if after treatment of periodontitis, the patient has inflammation, you will call it as gingival inflammation on a periodontitis case, not gingivitis. So you have to differentiate that. So these were clearly defined that what could you diagnose a case where you have reduced periodontium in a non-periodontitis patient. Non-periodontitis patients are where you do, for example, healthy patients where you do crown lengthening, or patients who have gingival recession because of trauma, but they do not have signs of periodontal disease. So such patients are not at risk of future loss. So they can be called as gingivitis because they have not been given the diagnosis of periodontitis. But patients who have been treated for periodontitis are stable and get inflammation later on. They cannot be diagnosed as gingivitis on a reduced periodontitis. They have to be called as gingival inflammation. So that was clearly said. So the good thing in this classification was they said clinical gingival health less than 10%, less than 3 mm, and health on reduced periodontitis also was clearly defined with non-periodontitis cases and periodontitis cases. And as I said, in non-periodontitis cases, even after it was called as gingivitis, in a periodontitis case, it was called as gingival inflammation. Risk, the differentiation was made because a periodontitis patient has always the risk of future attachment loss, which was absent in a non-periodontitis patient. So these were the case definitions. Now, case definition led to classification, and the classification led to diagnosis that patient with periodontal health or less than which should be diagnosed as periodontal health. Patient more than 10 mm, 10% of pocket depth, 10% of BOP and less than 3 mm pocket should be diagnosed as gingivitis. And similarly, any further patient of more than 4 mm attachment loss should be diagnosed as periodontitis patient. So this was clearly mentioned in this. Now, this was one advantage. Now, coming on to the advantages of plaque, what changes they have made, what good things they have made in plaque-induced gingivitis. Now, they have removed these three underlined. If you see the menstrual cycle gingivitis, oral contraceptive, ascorbic acid gingivitis have been removed from new classification because they find that there is no separate phenotypic, differences in menstrual cycle, oral ascorbic acid gingivitis, which you see from a normal gingivitis, which occurs because of plaque only. Secondly, also they find that oral contraceptive associated gingivitis is very rarely seen nowadays because oral contraceptives, the concentration of drugs which are given is very less and you do not see those effects on the gingiva. And ascorbic acid again is very rarely seen nowadays, so they have removed that. Also, another difference which they have done is now they have only made it into, mediated by systemic or local factors and drug induced. So they have kind of, reduced few of those categories from gingival inflammation, and this was one good change. And the good change which you saw was they have clearly stated that gingival index we generally use in our case histories, they said is not the right thing to, define gingival inflammation. Neither is the color, neither is the GCF volume, GCF proteins, none of them can be used to define gingival inflammation, nor the systemic markers, genetic markers, nothing is fit to be defined. They said only BOP has to be used because it is one of the first signs which can be detected. It has a histologic validation of quantitative and qualitative for inflammatory infiltration. It is an objective sign which has got high inter-examiner consistency. It gives you site-specific information where it is bleeding and where it is not. And as I said, is a prognostic inflammation, absence of bleeding, negative predictive values very high, almost 100%, meaning by that absence of BOP says that the diseases or inflammation is not there. And it also is a patient factor which is seen by patient in his mouth, can be used for patient motivation, education, monitoring of preventive and therapeutic measures. So none of those gingival index, which is most commonly used, is not the right measure gingival inflammation and gingivitis. So less than 10% what they defined was health, more than 10% up to 30% they said was localized gingivitis, and more than 30% was generalized gingivitis. The pocket depth in both the cases, health as well as gingivitis, remains less than equal to 3 mm. Now, the basic implication of health in gingivitis was that a patient with the BOP less than was called as clinically periodontally healthy, thereby meaning that a minimum level of inflammation was accepted as a clinical periodontal health, and absolute absence of inflammation has been changed now. Now, also they said clearly was that gingivitis is a clinical diagnosis. No information is not sufficiently available to define gingivitis on the basis of microbiology, because they have not been able, as in earlier studies, if you would find, they said A was more commonly seen in other classification, aggressive periodontitis. They could microbiologically differentiate different types of periodontitis on the basis of microbiology, which was not possible because there are no specific microorganisms which can be defined for gingivitis. So information is not available for molecular pathophysiological criteria of gingivitis, and radiographs again cannot be used. It is a clinical diagnosis on the basis of just BOP you have to define. So very clearly being mentioned in this classification. Now, they also said that because bleeding cannot be, you cannot say the amount of bleeding. So your BOP cannot be used to differentiate between mild, moderate, and severe gingivitis, but you can definitely use the number of sites to define the extent of gingivitis as localized or generalized. So you cannot ideally classify it as mild, moderate, and severe gingivitis. So they said, another thing which they said was, although severity could be matched, but you'll have to add a lot of other features. You will have to measure, for example, the amount of glandular fluid being produced, but that is all subjective and not clinically possible. So severity measurement is not possible, only extent is measurement, and BOP remains the only site. And also the good thing is they have defined the definition of gingivitis and how to use it in epidemiologic purposes and for a clinical practice, which I'm not going to go into details, because it requires a lot of time to explain that, but this is a good thing. So ending the health and gingivitis part, I would say these three things have been clearly defined now, that pristine health does not exist, clinical periodontal health exists less than 10%, and gingivitis cases more than 10%. In both the cases, the pocket depth remains 3 mm or less. Now, next group was periodontitis. Now, these were the people who were working on periodontitis group. Now, on the pathophysiological basis, they classified it into 3 groups: the necrotizing periodontitis, periodontitis as a manifestation of systemic disease, and periodontitis. Now, you have seen many epidemiologic studies across the world, across India, where they've tried to, see what is the prevalence of periodontitis, and you find various results, because there was no clear-cut definition which could say that this is the periodontitis, this mm of clinical attachment loss would be called as periodontitis. And as you know, as your minimum requirement of CAL to be considered as periodontitis goes up, the number of cases which will fall into that category will go down. My intention of saying that when you take as your baseline is 1 mm, you will have the prevalence increasing to 70-80%. When you have 2 mm, the prevalence will go down to 50%. When you have 3 mm or more considered as periodontitis, the prevalence will still go down to 30%. But every study had different criteria which was taken, and that's why you find a lot of studies with different results which are considered in, So in this classification, they clearly said interdental CAL of more than 2 mm when CJ detectable at 2 or more. So they clearly gave a quantitative measurement what should be considered as periodontitis and at how many sites. But they also put a caveat, like, in nowadays you have star applied, conditions applied. So they have used that criteria and conditions applied. The CAL should not be ascribed to gingival recession, should not be ascribed to dental caries, should not be ascribed to endodontic lesions through marginal periodontium, impacted wisdom teeth, to the distal of third molar. So that star and conditions apply have to be kept in mind while examining a patient and defining it as a case of periodontitis, that the attachment loss should not belong to these 4 conditions, the clinical attachment loss should not be out of the 4 regions which have been mentioned here. Then you call it as a case of periodontitis. The next thing which has been absolutely talked about from 18 to till now, everyone is going gaga about staging and caring. New staging and periodontal diagnosis was, staging and grading was introduced. Now, this was obviously based on the staging. They were taking it for oncology and they wanted to give it advantages of it. Now, in earlier diagnosis, when we used to call it as chronic periodontitis, severity and extent was always defined. We used to call it as mild, moderate, severe, depending on the depth of the pocket, and extent was localized or generalized depending on 30% and more than 30%. But now staging had third factors. Now that severity and extent was kept and included in this staging thing. But the third thing which came into practice, which got included, was complexity of management, depending on how many furcations are involved, how many vertical defects are there, how many teeth, loss has taken place, and how many ridge defects are there. So you had a complexity factor along with severity, extent, which has been added into this to come to a diagnosis, and which helps in telling a patient, telling a doctor, or from a diagnosis he'll come to know what level of disease does he have and what level of expertise or kind of treatment the patient would require. Then they also included grading. Now, grading was based on the basis of how the disease is progressing, how is he responding to treatment, and the effect of the systemic and the risk factors which were available, which Dr. Baiju was talking about, smoking and diabetes, which have been included in this class, basically the most common risk factors, and how do they affect the responsiveness and the grade, the progression of these. These were included. These are the two most talked about things of this classification, the staging and grading, and everyone is going gaga about, everyone is just talking about these two things. Now, important thing to note, which they said in this was, once a stage shifting complexity factor has been eliminated by treatment, the stage should not be closed. For example, if I show you in this, if suppose the pocket depth was 6 mm and you treat and the pocket depth comes to less than 6 mm, comes to 3 to 4 mm, that means that you cannot regrade the patient into grade, you cannot get to stage 2. His stage will remain the same as stage 3, because at the time of diagnosis it was always stage 3. So you cannot get the patient to a lower stage just because that complexity factor has been taken. So that means what we said was, after periodontal treatment, gingivitis patient can get to a state of health, but a periodontitis patient remains after treatment a periodontitis patient for life, and his diagnosis never changes. So that means they try to insist that a periodontitis patient would require a SPT for lifelong, and the patient has to be motivated for that. Very important. They said that, advantages of what staging, they said, and the good thing was that on the basis of this method, they said you could have a multi-dimensional diagnostic criteria. Now, earlier we used to diagnose the chronic periodontitis or aggressive periodontitis, mild, moderate, or severe. Okay. Now, that would not give you what exactly every 4 or 5 mm pocket, whether more than 5 mm, clinker attachment loss would be a severe chronic periodontitis case. You would not come to know how many teeth have been lost, how many teeth are present, how many sites are involved. But when you have a diagnosis like this, you know what is the rate of progression, what are the factors present, risk factors present, what stage is there, how many teeth would have been lost. So you have a clear-cut multi-dimensional diagnosis now on the basis of new classification. The second advantage is that it defines periodontitis at various points in time. Now, at this point, if diagnosis is this, the diagnosis. Now, earlier it would be chronic periodontitis and always remain chronic periodontitis, and you don't know what changes have taken place over a period of time, even if you have treated that patient. So you have individualized diagnosis now, which can be at with different points of time, which would help you in diagnosing and treating the patient. It also helps in communication and determining prognosis. Now, earlier when you tell someone that he has a chronic periodontitis, suppose he has only 5 teeth and all 5 teeth have more than 5 mm pocket, that also is a chronic periodontitis. You will not know what is the requirement, but with this you would know what are, grade you, for example, if I say stage 4, more than 6 teeth, have been lost. You would grade C. The progression is pretty fast. Currently unstable means the pocket depth is more than, so everything is very clear in this, and the prognosis of patient with new diagnosis. And as I said, it is taken from oncology. It gives a personalized diagnosis to patient. Now, earlier for every patient which had a pocket diagnosis, the common diagnosis, chronic generalized chronic periodontitis or generalized aggressive periodontitis, or maybe severe. Every patient who had 5 mm or more pocket would be severe generalized chronic periodontitis. But now you have an individualized periodontitis diagnosis, which may not be common to everyone. So you have a personal touch coming into this diagnosis, and every diagnosis will be a personalized diagnosis. So you have an individual patient which is getting concentrated on this. The last thing, peri-implant conditions have been added, which were never there into the classifications earlier. So this was the first time this classification has been added into the classification of periodontal diseases. So ending the good things here, because as I said, I've just concentrated on the most common things which we are going to include in this presentation. So we have eliminated the chronic, aggressive, and diagnosis, and you have new diagnostic criteria on the basis of what we have now discussed. Now, coming on to the demerits of classification. Now, you must have heard many people saying that 99 classification had many categories. Now, these were the major categories which 99 classification had, almost 8 categories, whereas the new classification has only 4 categories. But I feel it is an illusion. The better our illusions are, the faster the illusions are shattered, we'll get close to reality. Let me show you. Now, this was the subcategory of gingival disease in 1999. Okay, the subcategory, the subclassification under gingival conditions. Although, initial categories, it looks from 8 to it has just gone to 4, but you see the subcategories. These are the now subcategories of gingival. Now go later on. Now this is how abscess was classified in 1990. Now this is how it is classified now. You had necrotizing for ulcerative diseases classified in 1990 into 3 categories, but you have now so many subcategories in 2017. You had periodontal abscess, endoperioral lesions classified in 1990 into 3 categories, but now you have so many categories and subcategories. So it is hugely difficult to remember each case definition and apply clinically. And you see periodontal disease, systemic diseases affecting or periodontitis as a result of systemic diseases. These were the conditions, but now you see the conditions, and each one has been defined with a case definition. That means if you are using a Down syndrome, you need to go and know what is the Down syndrome definition and how would you define it. So humanly not possible to remember each case definition and apply clinically. Now, another disadvantage was that these were the people who were involved. The first photograph with Dr. Van Dyke sitting on the chair was the group 1 who was looking at group 1. The second is group, the biggest photograph is the periodontitis group 2, the group 3 and group 4. Now, one of the main, thing which was said was these were all, this classification was created by people who were mostly into academics, and this group did not have any private practitioners or private players of periodontal therapy who were practicing and were not into academics. And that's why you find this elaborate, detailed classification, which could be generally applied in a clinic. Maybe you can ask your PG to apply, but when you go to a clinical practice, you might not find that easy to apply. So that was one criticism of this classification. Then my take on extra health was a very good arrangement. But why was this included? I don't know why was this included in the diagnosis of periodontitis. They could have defined health and said anything more than 10 should be called as a disease, and they could have very easily eliminated from a classification. Health was not required to be included in the classification of gingival diseases. Then came necrotizing. Now, this was a group of periodontitis patients. Now, they just for, although the reason may be right that they have kept the necrotizing periodontal disease is a separate group of diseases which cannot be mixed with others. But under periodontitis, they have gingivitis also and periodontitis also. Whereas in the 99 classification, necrotizing group was totally different. They had the necrotizing periodontal disease. So it could have gingivitis and periodontitis together. But now in this classification, it is a periodontitis group. It is under periodontitis, they are classifying it as necrotizing periodontal diseases, and they call gingivitis included in this. Whereas you have a gingival diseases group separately. Now, another thing you see, the second group is periodontitis group, major heading periodontitis group, and again you have a subcategory which is also a periodontitis. So you have similar names being used in this classification. Now, when you read that 2017 document of JCP and American Academy document on classification, they say that the remaining cases of periodontitis who do not have local characteristics of necrotizing periodontitis or systemic periodontitis should be diagnosed as periodontitis, and further using a staging and grading system that describes clinical presentation should be defined as periodontitis. That means they say that you need to eliminate first systemic diseases, you need to eliminate necrotizing, then only you come to periodontitis. And it is not very clear here whether you can apply staging and grading to patients which have necrotizing periodontal disease or not? Okay, and can you apply staging and grading to these patients which have systemic disease or not? Now, another controversial question, which is, many people have raised a question, and I would show you the evidence for that elimination of localized aggressive periodontitis has been questioned. Now, localized aggressive periodontitis had three important things: the age criteria, the localization into incisors and molar, and the rate of progression. Now, these are three very important things which are present in localized aggressive. We're not talking about generalized aggressive periodontitis. So these were three things which differentiate LAP from any other periodontal disease. Now, in a letter which was published in JADA in 2009 by Dr. Fine and Gary C. Armitage, who also is a part of 2017 classification, he writes that localized aggressive periodontitis occurs in children and adolescents who have a significant periodontal damage localized to incisors and molars with rapid progression. By contrast, chronic periodontitis affects all the older adults and usually progresses less rapidly than ALA. So that means if you have these two conditions, under the new conditions, both could be diagnosed as stage 3 grade C. Now, they have given an example in this article where you had a 51-year-old and a 19-year-old. One, as per old classification, would be chronic periodontitis, and as per new classification, the lower case would be localized aggressive periodontitis. But now the diagnosis is the same. Now, in response to their letter, and in this article, they have clearly differentiated what are the factors on the basis of which you can differentiate these two categories. Now, in response to the second group was headed by Dr. Papavenue, and they responded to this letter to editor, and they said that depending on the extent of bone, they could classify the stage to stage grade C localized periodontitis in adolescent patients. And in the same letter, they say the lack of age specificity often rendered the distinction between generalized aggressive and severe chronic periodontitis impossible. Now, very surprising that the first letter did not talk about generalized aggressive, but they are answering about generalized aggressive. They already have said we're not talking now. In third response to this letter, Dr. Fine and Armitage again said that we agree aggressive periodontitis in older patients cannot be distinguished from chronic periodontitis. But they said our focus was on patients which have young onset of localized disease. We did not address generalized. The new classification does not address young onset of severe generalized condition, for which they were making an argument. They also said that, which, Dr. Baiju was showing about consensus. They said consensus we know is, general agreement or unanimity. Now, in this group, when they were discussing this classification, it is very well known that in this workshop, only a narrow majority were in favor of eliminating LAP. So it was not a consensus, which was almost 100%. There were many people who did not agree to this, just because by voting, there had few people, the voting was more in favor of, a consensus that it should be eliminated. That's why it is so. And third point they said was that because the trend is towards personalized, individualized precision, approach, we should keep this disease entity is a separate disease entity, and this should not be eliminated, and this is not acceptable. Dr. Zambon, who is a dean and distinguished teaching professor at School of Dental Medicine, University of Buffalo, also questioned that. He said that as described in 2000 word workshop, a unique phenotype and other features are available for localized aggressive periodontitis. Therefore, to satisfy the definition of disease, any deviation or interruption of a normal structure of function or part of disease has to be defined separately. So this reclassification is just not it is not an academic exercise. It has important implications for patients, clinicians, and researchers. So there are significant number of people across the world with localized aggressive periodontitis. So it seems that there should be a reconsideration of localized aggressive periodontitis as a distinct clinical entity. So these are the questions which have been raised about this. Now, as I said, we're talking about demerits. As I said, this is important that they define periodontitis with the star conditions apply. So when you define a periodontitis case, you will have to ascertain that recession is not because of trauma, endoperioral lesion is not draining through sulcus. You have to see that caries is a cervical reason. I don't know how caries is a cervical. Now, if you have caries, I have my own doubts. Caries in cervical region, if you have plaque, the plaque will cause gingival inflammation. I don't know how would you differentiate whether the plaque is because of caries or whatever the reason may be, but it will have inflammation. It is, I don't know how to do it. So, although I agree with, can distal to third molar infection cannot be called as periodontitis. That is one factor which I can agree. But other factors you will have to look into, and if you do not have clear-cut answer to these questions, I don't know how would you diagnose the case of periodontitis. Now, another thing which you have to see is that it says two detectable, CAL detectable at two or more sites. Now, if you have only one site, you do not call it as periodontitis. Now, I was attending one of the seminars by Dr. Purnima Kumar, who was part of group 2. And I asked her, that time she told that it can be called as the site of attachment loss or one site of clinical attachment loss, but cannot be diagnosed as periodontitis. But this has not been mentioned in the book, and no one who would not have heard from them, it is very difficult to tell them, or it is not written that how would you diagnose a single case of clinical attachment loss on one side. Now, coming on to the most term thing about grading and periodontitis, grading and staging of disease. Now, you see that they have used CAL. The fact is that the CAL is not routinely measured in clinical practice. Even in your normal case, unless in your colleges also, in PG also, if you're not taking the case history, you don't measure CAL, you just see pocket depth. So they have used CAL, which is not routinely used. This is the first major disadvantage. Secondly, measurement of CAL with the centers, when the CAL is just 1 mm or 2 mm, has its own errors. If inflammation is there, probe goes deeper into pocket and your measurement can go wrong. So they have mentioned in this document that misclassification of initial stage of periodontitis is inevitable. So unless other methods are validated, biomarkers and all, they say that identification of a case of initial periodontitis will depend on level of training and experience with periodontal probe. That means if the person is new to periodontal probing and does not know how to measure CAL, especially in the interdental areas, which is much more difficult to measure CAL, especially compared to buccal and lingual areas, your classification of staging and diagnosing in periodontitis can definitely go wrong. Then comes, complexity factors which have been added into the inclusion of complexity factors such as tooth loss due to periodontitis and angular ridges, which may be difficult. How many patients will be able to tell you who are, whether that tooth was lost because of caries or because of periodontal disease, who has never come to a dentist, who doesn't know about it? How would you diagnose or come to this, use this complexity factor when information from a patient does not come into? So they are not very well defined, cannot be used in a clinical practice. Then comes to grading. Now, I would humbly, very, very, disagree with what Dr. Baiju said, that we can diagnose the case on the basis of radiographs. Radiographs basically do not offer anything to diagnose. Radiograph gives you evidence of what, I take a radiograph today, it does not tell you what is the condition, it does not tell you the pocket depth, it does not tell you how deep is the pocket. It only tells you what loss has taken place in the past. So, and it is a two-dimensional picture. It is impractical to use progression rate depending on the excessive radiographs. How would you see what clinical attachment loss has taken place in the last 5 years? It is very difficult to diagnose. Secondly, another important thing about radiographs is that how many patients will have radiographs for 5 years to use this grading criteria? They don't have it. I will ask how many people in post-graduation have department keep radiographs of last 5 years to use this as a primary criteria to diagnose or direct evidence of progression of periodontal disease. Hardly any colleges or anyone would keep those. So using this criteria is impractical. Now, I will show you one case. Now, as in radiograph, if you see, you find almost, middle one. This patient, if you very carefully see, has cervical abrasions, or restoration near the bone margin. That means if you intelligently see this person, although on radiograph shows this much attachment loss, but did not have a pocket depth. So diagnosis on the basis of radiograph is not possible. Secondly, they said another thing is if you do not have radiograph, they said you use radiographic bone loss. Now, they said that it can be calculated by percentage of bone loss divided by age. And percentage of bone loss was bone loss by root length into 100. Now, for example, I have written it now 50 years old, has a 4 mm bone loss in 10 mm root. So 4 by 10, 4 mm bone loss, 10 mm root is 4 into 100. That is 40% bone loss. 40 by 50 is 0.8 mm. That means it becomes a grade B, moderate grade of progression of disease. Now, one thing which you have to understand is that now he is 50 years old. His permanent teeth erupted at 12 years or 13 years, and his deciduous teeth would have been lost. Now we are directly where these people, American Academy, have included the complete age. Where were those teeth were not present for 50 years? The teeth came at 30. If I say all the teeth were erupted 12 years, so that means his age, age of the teeth is only 38 years. Now, if I divide it by 50, it is grade B. But when I take the age of the teeth, which appeared at the age of 12, it becomes 38. So that means his grade changes. So this is, by default, you have taken it from, the child was born, from the time he is born, his age has been considered. But where were the teeth? Where was the periodontal disease at the time of birth until 12 years the permanent teeth erupted? Second thing, now if I give you an example now, suppose I am now 50 years of age. I go to a dentist and I show him my teeth and he says 4 mm and same, he diagnoses me as a grade B 0.8. But by default, here you are taking that my disease started at 50. Now, suppose if I was fine till 45, I did not have any periodontal disease and my disease started in only last 4 years. How can we determine when will the disease start? If you cannot determine, the grading becomes wrong. Now, suppose my disease started, my grade, my bone loss would be 10. Now it will be more than any grade C and grade B. So till you cannot determine when the disease started, grading is arbitrary and on the basis of, where you have no proof to say how did the disease or when did the disease start. And it is not very, for me, it is not very practical to give a grading on the basis of criteria they have given. Okay, so the third criteria they said is phenotype. Heavily deposits grade 1 with the level of destruction. Now, if patient goes through a scaling, gets a scaling done from someone and comes to you after scaling and all, everything has been done, how would you grade it? Because you will not have deposits, only you can see the other. So it becomes very unrealistic to use a case phenotype also to grade. Then the third thing, periodontitis as a manifestation of systemic disease. Now they have made it 2 groups. Periodontitis as a manifestation of systemic disease in grade 2, or what in the second subgroup, and you have systemic diseases in the affecting periodontal supporting tissue in the third group, other affecting periodontium. But on a single table. So why, if they have a single table, why was the need to mention it in 2 subgroups and make it 2 subclassifications? I have no answer to it. Okay, then they say that in case of diabetes, there is no characteristic phenotype feature that are unique to periodontitis in diabetes mellitus. On this basis, diabetes-associated periodontitis is not a distinct disease. Nevertheless, diabetes is an important modifying factor and should be included in clinical diagnosis as descriptor according to new classification as glycemic control. And same thing is said about smoking. That is no unique periodontal features of periodontitis in smokers. On this basis, smoking associated periodontitis is not a distinct disease. Nevertheless, smoking should be a modifying factor of periodontitis and should be included as a descriptor. Now, in the systemic diseases, now they say the diagnosis for systemic disease is associated with diabetes. But here they say that it cannot be included in diagnosis. It should only be considered as a descriptor. So 2 contradicting things which I did not understand. And then they say that after diagnosing this, now here they say you have to use grading and staging as per the periodontitis classification. So that means earlier statement where they said that only cases which are when we eliminate necrotizing and systemic disease, those cases have to be diagnosed as periodontitis, and further staging and grading has to be applied. Here they say it has to be applied to all the cases. So a little bit of confusion. Now, third category will come to the important thing is mucogingival deformities. Now, the definition of recession they have given is recession is defined as apical shift of marginal gingiva caused by whatever conditions. Important here is it is associated with clinical attachment loss. This may apply to all surfaces, buccal, lingual, and interproximal. And the classification which they use is Kairos classification, which talks about classification of gingival decision only on the buccal aspect. Now, my question is, does the decision not take place on lingual or parietal surfaces? You had a better classification, where all the interdental, parietal, and lingual classification has been classified by some Indian, but it has not been used. Now, another important thing in this classification is the important landmark of mucogingival junction has been eliminated. Now, third thing which you see is if you go and read Kairos article, that classification was applied after a phase 1 therapy or scaling was done. So that means, does this application of this classification we have to apply only after we have done phase 1 and inflammation has gone down to cut? That means, can we not apply it on a case when it comes into a clinic and when you are taking a case history and diagnosing, your decision classification becomes inapplicable? Then they say we have to use this, where you have to measure gingival thickness, keratinoid tissue width, and they also say that hypersensitivity, non-cilious lesions, thin biotypes are the reasons for treatment of gingival recession. Now, does the thin biotypes do they require treatment or not? Now, in one of, I would tell you my personal experience, one of webinars where Mariano Sanz was explaining this classification, I asked him this question. Why this classification? You said about hypersensitivity is one of the main reasons why the decision has to be treated. I asked him, does hypersensitivity does not occur on lingual surfaces? Does thin biotypes which are prone to more recession not occur on lingual sites? He said, they do occur, but there you can use, his answer was, there you can use only these desensitizing toothpaste treatments are not required. So that was a very, very illogical answer. When you treat it on buccal side, the same treatment and same risk factors occur on lingual side also, but they have not been included in as per the gingival decision classification. Then comes the they say these localized factors that modify or predispose to gingival diseases. That means, if these factors are present, they will only lead to gingival diseases, that is gingival inflammation, because they accumulate. If these were risk factors, why the risk factors have to be included as conditions affecting it? Ultimately, these risk factors everyone knows, and they know that these causes gingival diseases only. Have all the risk factors which cause periodontitis included in the classification? Now, in the same document, they say tooth anatomic factors are related to dental plaque biofilm-induced gingival inflammation. That diagnosis was already there. What was the need of including these risk factors? They could have just made a point under that. These are the risk factors which are present, and presence of these can lead to a plaque accumulation. There was no need for having that in the classification as per my intuition. Now, as I said, coming to the end, the talk of the town is only staging, grading. Everyone is, tom-tomming about the staging, grading, but that also has a problem. No one is looking at other aspects of such a huge classification, such a massive sub-classification which has been included into it, categories and categories which are impossible for someone to read. So, summarizing, the good, as I said, is the case definitions. The good is inclusion, definition of periodontal health. Partially good is the staging, which, if I consider that, it gives you a personalized diagnosis, gives you complexity factors, gives you, the staging, but, it has its own perils, which I've already talked about. The good thing is the peri-implant disease has been included. Bad is a long list, which I've already talked about. I need not summarize them again. Ugly part is, that we are overlooking everything else and just talking about the staging and grading. The total concentration is on how to apply staging and grading. The total concentration is only on one disease. And the worst part is that it was introduced in 2017, came into literature in 2018. We are at the starting of 2022. We still do not see many people applying it. We still do not see this classification into books, still because of its inherent problems. And if I tell you 99 classification, we had an edition, 9th edition of Glickman, which came into 2002, and that classification was incorporated in 2002. We are 4 years over, and still we do not see that application. We are still hanging on to 1999 classification because of its easy usage and applicability. So this is the history of classifications of periodontal diseases right from 1879. We see so many classifications. So we had almost 145 years, 26 classifications, and last from 1989, 1993, 1999, and 2017. So if you see 90s, every 3 years we had one classification. Maybe American Academy, European Academy are too focused on giving classifications, and then we had almost 17 years or 18 years of gap. So the next thing is, the question is, how long will this classification last? And the wait is, on for the next classification to come and maybe cover up for the problems which we are facing. Thank you so much for your patient hearing. I hope, limited time I have been able to point out the merits and demerits of this classification and the problems which PGs and we are facing in clinical practice. Thank you so much.
Thank you, Ashish, for that wonderful presentation. In fact, the lot of doubts which our people had in our regarding this new classification, you have rightly addressed it, especially regarding the aggressive periodontitis. And since we are generally mild people, we don't voice it too vocally. But as you said, there are a lot of plus points in the classification, but there are even more points that should have been addressed. So as you said, probably the day is not far when we'll be waiting for a new classification. And one point which you stressed rightly, this classification came out in 17. Even in 22, it has not come out in our textbooks, which is limiting us from teaching our undergraduate students because they are not able to refer any textbook where they can get this new classification. So these are some of the drawbacks. What do you say about that?
Yes, sir, and good that it has not come to textbooks, because if it comes into textbook, it will become difficult for us to teach at the UG level. So it is a advantage, what do you say, in disguise that it is not coming up. And practically, sir, that is what, as I said, no, it is an illusion that, it is the easiest classification, but there are so many subcategories, so many conditions apply to it that practical application of this classification is not that easy. As I said, they have put us CAL. CAL, how many people measure CAL in everyday practice? None of us measure CAL in practice.
There are a lot of limitations on the practicability of the classification.
Yes.
And so
that radiographs is of no radiographs, and that especially the grading age they have taken from the time of birth. The teeth are not there. See, I have taken it at 12 years. If your grade changes because your teeth erupt at 12, and 12 also you don't have disease. It slowly appears after 30 years of age. Still, we do not have where we can really, say when the disease starts. Grading is impractical.
Yes.
How many colleges, as I said earlier, how many colleges who keep the record, have 5 years of their patients' record for X-rays where they can grade their patients?
Difficult. So on a lighter note, when can we expect the next classification?
Whenever these Americans will feel like having another get together, they will have it, sir. But the question, my question is very different. That why should we follow these Americans? And why can't we have a Indian classification which can be followed? Why should we follow these? We are out of our dependency on these people, and we should do it on our own.
Yeah. Anirban, our Honorable President talked about it in his inaugural address. I think it's time you senior people start looking into all these things.
Sir, you people have to take the lead, sir, and guide us, sir.
Few questions, and our Dr. Baiju is in a hurry to go, so I'll just take those questions. He has to leave somewhere.
Yes, sir.
Baiju, are you online?
Yes, sir, I'm online.
Dr. Kalsi, sir, has asked a question. Clinical attachment level gain and probing pocket depth reduction after regenerative surgery may usually result only from tight adaptation of the gingiva to the tooth surface, where actually no new attachment may have occurred. So this means that the probing pocket depth may actually not have improved to less than 3 to 4 millimeter. So this may mean that a larger probing pocket depth will actually exist but does not get recorded. And is this acceptable in the light of the 2017 classification? And does this same dilemma not exist for root coverage surgery procedures in recession cases also? Please clarify.
That's a good question. Actually, what we have to see is we have to look everything from a totally clinical perspective. We have to come out of the periodontics PG clinic. And we have to sit in a clinic where we are seeing patients, a general dentist or a specialist.
Yes.
If you take the view from a specialist view, because the beauty of the new classification is a practice-based classification. You can apply it in the clinics. I encourage all of you to follow the BSP implementation criteria of the new classification. They have made it very simple.
Yes.
They are not taking into consideration CAL at all for diagnosing periodontal disease. You don't need CAL to diagnose periodontal disease. If you have radiographic evidence of bone loss that is not due to non-periodontal reasons, that itself is periodontitis, because periodontitis is definitely an irreversible conditions. When you have periodontitis, you cannot go back to gingivitis. But the CAL and the PPD will give you the current status. Suppose the PPD is DAPR, that means you have to do some treatment for pocket reduction therapy. And coming back to the question, Dr. Calcius' question, we have only surrogate markers to follow periodontitis, to address periodontitis, whether the patient is responding to treatment. We don't have any other markers. So in a clinical setting, what we rely upon is PPD and CA to determine what kind of treatment the patient requires, especially PPD. So for all all the systematic reviews that they have commissioned for this guideline development, they have considered PPD reduction as the outcome measure, except for regeneration. In regeneration, what they say is PPD reduction is of course there, but CAL gain is also considered as the outcome measure. So apart from that, another criteria that what we can see is the radiographic evidence of bone fill. So we have to see from a clinical point of view. In a clinic for a patient, what matters is the PPD reduction. Because if you can attain a PPD less than 4 millimeters, that you can bring back stability. And that patient can be maintained for over a period of 10 years or 15 years or 20 years if he reports to SPT visits. So it doesn't matter whether it is histologically what you're getting is periodontal ligament or Sharpie's fibers or bone fill. And from a clinical point of view, what matters is what is the depth of the pocket at present. Is it manageable for the patient to maintain, as well as for the periodontist, to maintain stability for a longer period?
Professor Mejo Anbukin has got a question. Kindly advise regarding the use of water pick. I think it's meaning about the subgingival irrigation systems. How effective is that?
So all these home care devices, the self-care devices can be used according to the patient's convenience. Suppose certain patients will lack this dexterity. Suppose we insist that the patients should use the site-specific interdent brushes and all. But it is very difficult to practice oral hygiene. So it takes a lot of effort for the patient, and to sit with the patient. The clinician also should sit with the patient and should identify which is best for that particular patient.
Yes.
The patient feels that a water pick is convenient for him, especially when they have long span bridges and all, where this floss will not be effective. So these super floss water picks can be definitely used, but the patient's preference and their ability to use these products are the criteria to use any particular agent or device.
There's a question from Dr. Vamsi. With the current concepts of dysbiosis and PSD, why are probiotics not recommended as adjuncts to periodontal therapy?
Because there is no strong evidence. Because these days we rely on evidence. Unless you have a published evidence, that means there is no scientific backing for it. But individually, we all know that there may be expert opinions, there may be your personal experiences that probiotics are effective. The new guidelines does not discourage the use of probiotics. Yes. They say that they are not recommended for routine use.
Routine use.
We cannot recommend it for routine use, but all your patients should take probiotics along with subgingival schedule. That is not there. But individually, on a case-by cases, the clinician can decide whether it works or not.
Last question from Dr.
Because guidelines can only be guidelines cannot be a cookbook, sir. Because you have to modify and employ the guidelines.
Yes.
Guidelines are for the average patient. Guidelines are for the average patients and the average clinician.
Probably in future with
situations, you have to modify and adapt.
Probably in future with more evidence, the position may change.
Definitely. That is why they are the lifeline for this classification only till 2025. After that, they'll again come out with a new guideline. Not a classification, sorry, a new guideline.
Last question from Dr. Abhinash Patra. Are the use of adjuncts, what we have talked about, been assessed in an Indian scenario also?
We hardly have any. We have. I told you there are plenty of studies regarding adjuncts, especially from the Bangalore group. Our past president, Pradeep sir itself, has published a lot of randomized control trials. But the evidence base, when it is taken up for systematic review, what they have considered is the outcome. There are a lot of heterogeneity among the included studies. So when there is a lot of heterogeneity, you cannot come out with a concrete conclusion in a systematic review. That is one of the disadvantages of a systematic review. But there are a lot of advantages for systematic review also, because there is no substitute for it. So you have to follow that. Right now, what we have is a systematic review and the methodology for a systematic review. Knowing the limitations of the systematic review, what we can do is we can just follow that.
Thank you, Dr. Baiju. No.
So can I leave, sir?
Yes, sir. Yes, I'm sorry to keep you waiting.
Thank you so much.
Now, Ashish, we are just projecting the certificate on the screen. Please accept our small token of gratitude from our side. I know you have put in a lot of effort for this talk. Before concluding and before, I just want to make an announcement. For the notice of the delegates, the feedback form is given in the description. Kindly fill up the feedback form and you will get your certificate of participation. Now, may I request Professor Dr. Amita Ramesh, Professor and Head of the Department of Periodontics, to conclude this program. Over to you, Amita.
It was indeed a very excellent presentation, both by Dr. Baiju and Dr. Ashish. I think they have almost clarified all the doubts of the participants. We are indeed very privileged to have both of you, renowned speakers with extensive knowledge. It was very beneficial. I sincerely thank both of you, Dr. Baiju and Dr. Ashish, wholeheartedly. I also thank the President ISP and Secretary ISP, Scientific Convener ISP, and PEP Coordinator ISP, and also the EC members ISP and Life members ISP for attending and contributing. I also thank the Program Coordinator, Dr. Biju, for conducting the program so efficiently. I also thank Dr. Rahul Mandari, the Chairman, Dental Education Unit, for his support. I also acknowledge the contribution of each one of the faculty from the Department of Periodontics, ABSM IDS, for the success of today's program. I also thank the participants who have logged in such large numbers, which is the backbone of success of today's program. Thank you, one and all.
Thank you, Dr. Amita. Now, as we come to this end of the program, I thank the delegates who have sat for more than 3 hours here. Thank you, one and all. Kindly don't forget to fill up the feedback form and get your certificate of participation. Thank you.